Good morning. Welcome back. So we have a few housekeeping items to remember. In-person attendees need to sign in the sign-in sheet for today's session if you've not already done so. A reminder that all virtual participants are set to mute. If you have a question, please type that in the Q&A box, and we'll get the speaker to address that at the end of the session if time permits. If not, we will collect the answers from the speaker and distribute the responses to all of the registrants. All presentations will be available to view on demand online for 1 month following the conference. Attestation forms needed to claim CME credit may be completed by the attendees today at the close of the conference. These forms will be distributed in person to attendees and are available online for our virtual attendees. PDFs of today's presentation are available at LMU-DCOM, and disclosures for all speakers are available for inspection at the office of the LMU-DCOM Director of Alumni Services. Dr. Ansel Peacock is a family medicine physician at Farragut Family Practice in Knoxville, Tennessee. He graduated from the Kentucky College of Medicine in 2017 and wanted to complete a traditional rotating internship at Lumberton, North Carolina, followed by a family medicine residency at Lake Cumberland Regional Hospital in Somerset, Kentucky, where he served as chief resident. He practices a full spectrum of family medicine, including pediatrics and osteopathic manipulation therapy, and has been able to fill a void in Knoxville by providing inclusive care to the LGBTQ+ community. Outside of medicine, he spends time with his wife Allison and their dog Jane, hiking, camping, and playing soccer. Please help me welcome Dr. Peacock.
Thanks, everybody. Thanks for having me back. I was here last year. I did more of a preventative screening aspect for the LGBTQ community. There was more interest in some of the medical side of transition, so that's what today's topic is. I don't have any disclosures. I just love what I do. And then, so our learning objectives, fairly similar at the beginning as last year's. Again, be able to understand the difference between gender, sex, and sexuality, understand how to make the diagnosis of gender dysphoria, understand the difference between social and medical aspects of gender transition, also being able to understand and be comfortable with both transmasculine and transfeminine hormones and how to start them, as well as just becoming familiar with gender-affirming surgeries. Again, I am not a surgeon, so we won't go into the details of those, but just kind of the way if your patient comes in, you know what to expect and kind of how to navigate that conversation. So just going to start with some basics. These first few slides we're going to go fairly quickly, but just the difference between sex and gender. So sex is what is inherent at birth. These are the chromosomes that you have, what your external genitalia looks like. And then gender is what's influenced by external factors. So this is how we dress, how we act, how we walk. These are both behavioral, cultural, and psychological traits. Most of you have seen a lot of these terms, the LGBTQIA+. This is kind of what they're going into, and there's a lot more not on the scale. So again, this is just more for your information, but the one that I'd want you to kind of not remember is this one, the transsexual. This is more of an outdated term. It's a lot older ways of looking at a transgender person. Some people will still identify with this word. A lot of times it's the older community or someone who has had a gender-affirming surgery. I bring it up because there is an ICD-10 code, and so a lot of us will type in, transgender into our EMR, and certain words pop up. Transsexualism is an ICD-10 code. You can use gender dysphoria, so I just wanted to kind of point that out so that you would kind of be aware of it when you are seeing it. This is probably my favorite picture to show everybody when I do these lectures, the genderbread person. I really like it because it encompasses the spectrum that the LGBTQ+ community is. And it breaks it down to 4 big components. So gender identity is what's in your head. Gender expression is what you're wearing, how you dress, how you walk, how you act. Biological sex is, I understand there is definitely more of a binary between, XX and XY, but I like this spectrum because there are differences in sex development that I'll briefly touch on, or intersex disorders. And so there is a spectrum. Sometimes our chromosomes aren't one or the other. Sometimes there's a range. Sometimes there's mosaicism. Sometimes our external genitalia doesn't form the way that our chromosomes say it should. So there is a spectrum as far as biological sex, but again, we're taught to not ask about, genitals or what's, just on the street, not in the medical aspect. But, and so there are things, people walking around with differences that we're just not aware of. And then sexual orientation is who you love. And so what I like about this is it shows that each aspect is very different and everybody can fall on the spectrum at different points and times. I kind of used to joke and say different times of the day, depending on the person. And so I think this is a great way to break it down to kind of the outside person. So differences in sex development, this is the newer term for intersex disorders. So this is a group of diverse congenital conditions. So again, this is how you're born. This can affect your sex chromosomes and external anatomy, but they can correspond with anything on that spectrum that I just showed you. So the differences in how you identify, the differences in how you dress, the differences in who you love. But I like this because this is a biological fact that your chromosomes and your anatomy may not align with the way you act and feel. So these are just some basic examples. Again, I'm not going into detail on these. I just wanted you to kind of refresh your memory with these. So Klinefelter syndrome, Turner syndrome, those are the big ones that we're aware of. But even simple things like hypospadias and micropenis, clitoromegaly, these are all things that are different than how we're supposed to be, but they're very, very common. So again, how common are these? So people just between not XX and XY, that's 1 in 1,600 births. Klinefelter's is 1 in 1,000. So there's a lot of people walking around with these differences in sex development that we're just not aware of. So if you think about Knoxville, for example, and how many hundreds of thousands of people are in Knoxville, take a 1 in 1,000 birth and we're looking at a couple hundred people. So transgender, this is the one that my topic is really based on, so I wanted to pull this one out. So these are people whose gender identity and or gender expression differs from what they were assigned with at birth. So terms that you're gonna see me use are F to M or M to F. These are female to male, male to female. We're looking at, transmasculine, transfeminine, and you may even see me or hear me use assigned female at birth and assigned male at birth. These terms are great because it really identifies, especially in our medical charting, what we were assigned with at birth and how your patient's identifying, especially when you're using gender-affirming pronouns. So again, other terms that you may see when you type in trans to go and find transgender, you'll see transsexual pop up, which we briefly touched on. You'll even see transvestite pop up. So I like to pull this one out again because if it pops up, you're aware of it. So transvestite is typically a term that's used for someone who likes to wear clothes that are different than what they're expected to wear. This is not a sexual orientation. This is really just done for pleasure, whether it's sexual pleasure or identity pleasure, but it doesn't mean they're gay, doesn't mean they're lesbian. It's just, they just like to wear the different clothes. And oftentimes it's used for entertainment purposes, like drag, for example. So again, just be aware of that term because it'll pop up and we might use it inappropriately. So gender dysphoria, as far as the DSM-5 goes, there is the IC-10 of F64.9 that we can use, but this is really an easy diagnosis to make. So in adolescents and adults, you're looking for at least 2 of the following of these criteria that last over a period of 6 months. So we're looking at just a marked incongruence between your experienced gender and the gender that you were assigned with at birth, but also that incongruence between your primary and secondary sex characteristics that you just really don't desire. We're looking at a strong desire to get rid of our primary or secondary sex characteristics, also the desire to be another gender, to be treated as the other gender, and that even how you react to situations are those of the other gender. So now, when it comes to kiddos, it's a little bit more in depth. You have to have 6 of these for 6 months. So it does take a little bit more of that diagnosis when we're looking at pediatric patients. But the biggest thing is really it's how they dress and how they play. That's the biggest thing that we're looking at, whether it's who we play with, what toys we play with, and then again, once they start becoming more aware of their sexual anatomy, kind of that desire, that persistence to be rid of their sexual anatomy, and then once they become aware of the opposite gender and realizing, that may be more desirable to them. So when it comes to transitioning, these are the 3 biggest aspects that you'll see when someone is transitioning. You're going to be seeing a social legal aspect of it, gender affirming hormones, or gender confirmation surgery. Or really nothing at all. I like to throw that in there because just because you identify as transgender doesn't mean you have to do anything about it. And some people don't just because of the social aspect of, will my family accept me or not? Doesn't make them any less transgender. So what is our role in the medical transition? So this is really the meat and potatoes of my talk here. So social transition is one of the easiest ways that we can transition. It is reversible. I think that's the biggest thing that is important. This is reversible. So this is something that you can do with a pediatric patient. But this is really just changing their name, changing their hairstyle, allowing them to dress in the clothing that makes them feel comfortable. And then I also talk about, binding, tucking. These are just ways that you can hide the anatomy that you're born with so that you can pass more out in public. You also, as a provider, when they start to come out, they're going to come to you and they're going to talk to you about, what the next steps of transition are. And so you can help them navigate, what that looks like coming out to family, friends, making sure that they have, therapy and things like that. That's probably one of the biggest things that I do when someone comes to me to talk about gender transition, is I kind of assess their safety when it comes to coming out, especially in the South, because once they start medically transitioning, it's going to become more apparent. And so somebody may get kicked out of their home and now they're homeless. So different things like that. But also if it's a pediatric patient and they're going to go into the school system and they want to change their name, maybe use a different bathroom. This is something that you can help navigate with their school, write letters, talk to their teachers. But again, creating that safety plan, what happens if they get bullied, what about social biases at work, but then also providing medical documentation for their legal name change, for their surgeries. A lot of times they just need a letter. I keep a template saved on my computer, and then that way if they ever needed it for name change, license change, surgeries, you already have it ready to go. Pronouns, again, is a reversible thing that you can do, but this is probably one of the easiest things that we can do. And it's really important that everybody tries to display their pronouns. I think the biggest thing is everybody does it, one person's not singled out. And I think that's why you're seeing a lot of social media allowing you places to display your pronouns. It's just because, again, if everybody does it, if one person starts, displaying their pronouns for that change, it doesn't look as strange. But common ones that you're going to see are she, her, hers, he, him, his, and they, them, theirs. Those are probably the biggest. You occasionally will see a these, I, here. I have a patient whose partner is a its, which was kind of an interesting one to me, but there are a lot of different pronouns. And I think just if you know that your patients in the community that may have a different pronoun, just go ahead and ask them what they prefer. My EMR, Athena, actually allows me to put it in the header so that when they come in, even if they have their birth gender, which will show up on my main schedule, but then their preferred gender shows up in their chart, and then I can also have their pronouns as well. But again, misgendering is a big cause of anxiety for these patients, and so I think the biggest thing is your intent. So if you accidentally slip up, it's okay. Just say, hey, I'm sorry. And a lot of them are much more flexible. But I think the biggest thing is to just apologize if you mess up, misstep. But also when it comes to your medical documentation, patients may request, their records, and if you're saying, so-and-so is a assigned female at birth transgender patient, and and then you start saying he, him, his as far as your pronouns in your statement. All of a sudden at the very end, you start switching back to she, her, hers. Then that can just look, bad to them. So just try to be consistent with pronouns because that's super, super easy. So hormonal transition is usually the next step. And so I do want to point out that right now in the state of Tennessee, any medical transition in a patient 18 or really 17 years and younger is technically illegal. We're not allowed to do pubertal suppression anymore. So I just kind of want to point that out, but I want you to be aware of it because some patients are traveling out of state to do this. Or they may be transitioning with cross-gender or cross hormones. So I just kind of want to make sure that you're aware of what's used. So the biggest thing is puberty suppression with gonadotropin-releasing hormones. I think this is really beneficial for youth because it stops puberty in its tracks wherever they kind of start the hormone. This can make it easier for them, especially as they're exploring their gender identity. This is fully reversible, which I think is really important. Really, if you were to start a pubertal suppression and then a patient decides they want to go through their natal puberty, all you have to do is stop it and puberty just resumes as normal. But this can really ease a lot of anxiety, whether it be social or physical, but it's super simple. And so we simply do it with gonadotropin-releasing hormones. And I threw the picture of the pituitary up for you all to see where it blocks. But essentially it blocks at the pituitary gland, stops that production of FSH and LH, which then downregulates their gonads into producing the hormone that would move forward their normal puberty. Now, the secondary part is, again, the cross hormones, and we'll talk about those here a little bit later, but those cross hormones, these are partially reversible. So a lot of times once certain things change, usually more on the masculine side of the gender spectrum, you can't really reverse that, and we'll go into that. So suppressing puberty, fully reversible. Once you start doing cross hormones, this is only partially reversible. So puberty suppression, typically, we want to try to start it, if you're going to start it, around Tanner stage 2. There's really no benefit in starting it any earlier, but if you wait longer to start it, especially in a trans feminine patient, you allow a little bit more penile growth, and that penile growth may allow for more tissue during their surgical transition later, and so I'll kind of show you that picture too. But really, Tanner stage 2 is ideal, and then if you start it later, if you started at Tanner stage 3 or Tanner stage 4, there's no benefit or no benefit, but the biggest thing is you're just going to stop puberty where it is. So if puberty's already kind of started, and that's starting to cause some distress, you can kind of say, well, I can stop it where it's at, but I can't take it back in time. So that's a big thing, to set those expectations for your patients. As far as suppression regimens go, typically with those GnRH analogs, you're looking at hystrelin or leuprolide. Hystrelin is an implant that would go in the arm. It is changed usually every year. Sometimes you can get a little bit longer out of it, especially if their hormone levels are staying low, but a lot of times it's changed yearly. The leuprolide allows a little bit more fluctuation, so these are usually, injections that are usually given monthly, every 3 months or every 6 months. There are other anti-androgens that I'll talk about with the trans feminine cross hormones, such as spironolactone. But, so these are things that you can start. I think the biggest thing to know is that there is no standardized regimen. Everybody's going to be different. Everybody's going to respond different. Everyone's going to have different goals. Some people may not feel comfortable with an implant in their body. Some people may not like shots, and so you're going to need to go with something like a spironolactone. So the idea is kind of assessing their goals at that point. As far as, continuing and discontinuing, you can use GnRH analogs for their androgen suppression, specifically the entire length of their transition, but of course you have to watch out for side effects. But typically if you're stopping it, you want to stop it once they're 1 to 2 years on their cross hormones. As far as gender-affirming hormones, so this is kind of that next step. So this is, after puberty has either happened or is delayed, and now we want to start those secondary sex characteristic transitions. So again, cross hormones, that's what we're used for that secondary. How you do it is up to you. There's the referral letter, meaning they've seen a therapist. They have a letter that says, I'm in the right state of mind. I know what I'm getting into. I do desire the secondary sex characteristics, versus informed consent. And you'll see a lot of this with like Planned Parenthood does a lot of informed consent. There is an online like mail order doctor that you can use called Plume. Plume does have them see a therapist at least once. But I think it's up to you. I do a mix of this in my clinic. I understand that a lot of patients just don't have the resources to get to a therapist. Again, sometimes they're trying to transition without their parents knowing or something like that, especially once they turn 18, but they're still on their parents' insurance. So I do a mix. I definitely prefer to have the referral letter if I can get it, because I know that they're seeing the therapist. They have that backup, when they are starting to transition, in case there's any roadblocks they bump into with family, they've got someone to talk to. But if they come to me and they say, I just don't have the resources, then we have a very long discussion with informed consent. And I usually see them once or twice before I start hormones that route. Any contraindications with this would be for trans feminine patients, if there's any family history of estrogen-sensitive tumors, especially if they're older, trying to make sure there's nothing else going on that you may awaken with hormones. What is their risk for blood clots as well as liver function? And then as far as the transmasculine, same thing, any testosterone-sensitive tumors. Any pre-existing polycythemia really should be worked up prior, because testosterone often increases that red blood cell count. And of course, liver dysfunction. So again, if they're already on pubertal suppression, you would start this around age 15 or 16. It's usually when their classmates are starting to go through puberty is when you want to tie it up with them so that they're transitioning about the same time and going through the same thing that their peers are. There's really no limitations on who can do this. It's very similar to doing, really affirming hormones in a cisgendered patient. Someone who might be menopausal or low testosterone male. It's very, very similar. So as long as you feel comfortable with hormones, you're able to do it. Routine monitoring, obviously we want to definitely do estrogen, testosterone levels, renal function, liver enzymes, as well as A1C and lipids. And we talk about this here in the next couple of slides. So we're going to start with trans feminine hormones. Trans feminine hormones are usually estradiol, progesterone, and then obviously, and then the anti-androgen. But our goals are essentially that redistribution of body fat. They're looking for less central fat, more on the hips, to give them the curves. You'll see a decrease in muscle mass and strength, some softening of the skin, a decrease of sexual desire. Usually, breast growth is one that's wanted. You will see some decrease in testicular volume, decreased sperm production. So these are kind of the big changes that people are going to see when they start estrogens. Really, the onset of these transitions is around 3 months. Sometimes it's closer to 6 months, depending on how well they respond to hormones. And then as you keep them at level, they'll see changes up until about that 3-year mark. And then at 3 years is why I say, now you're just going to age naturally. And so I kind of set those expectations for them. I think the biggest things you want to watch out for is that increase in migraine, mood swings, hot flashes, weight gain, and then bone loss. So we know that testosterone does have that anabolic effect on our bones. And so when we're decreasing that testosterone, we have to watch out for the bone health. So 17-beta-estradiol is the estrogen that's typically used. This is considered bioidentical. We typically don't use the conjugated equine hormones anymore. I think the biggest thing is the blood levels. It's a lot harder to get it in range, but also there's that increased risk of blood clots, as well as cardiovascular risk when you're using the equine estrogens. And so typically 17-beta-estradiol. Oral, sublingual, topical, patches, injectables, and even pellets are available. So there's a lot of different ones out there, and you can usually find one that your patient would like to do. So this table is from the University of San Francisco, or University of California at San Francisco's website. The link is at the end. But this is kind of just basic how to start it, initiate it, and then kind of maximum doses. I like to say, as far as the maximum doses are concerned, not everybody will get to therapeutic levels at this max dose. And so you can push it a little bit further, but everything needs to be monitored very, very closely. Sometimes you just have to change their anti-androgen as well, which we'll talk about on the next slide, I believe. So typically injections are weekly or biweekly depending on their fluctuations, and then tablets are every single day, usually twice a day once you get above 2 milligrams. So as far as to testosterone blockade, again, this is not required, but it does help you get to the levels that they desire quicker. It also allows you to use lower doses of the estrogens. So spironolactone is the one that you'll see most trans feminine patients use. They'll call it Spiro most of the time. So if they come to you and they say, yeah, I'm on Spiro, this is what they're referring to. So again, you typically, low dose, you'd be like at 25 milligrams per day, but then I typically start 50 milligrams a day, and then I titrate up as needed and as tolerated. You can use finasteride and dutasteride to block. Dutasteride actually blocks it a little bit more aggressively, which is good. But most patients usually want to go the spironolactone route. I don't know why, it's the diuretic, but they choose to do that. A lot of times it's that sexual side effect with the dutasteride. These patients may still be using their penis for intercourse, and so if you block testosterone too much, they start to have erectile dysfunction, and that's not desired. Bicalutamide is now an option. Bicalutamide is a direct androgen blocker. That was typically used in patients that had prostate cancer. But now that it's gone generic, it's more affordable for patients, and so it's an option. The biggest thing is that you have to watch out for their liver function. But it's very simple. It's just 50 milligrams a day, once a day. There's really no upping or lowering it. So it's probably one of the easiest ones to dose. And then as far as progestins, these aren't required. A lot of it is anecdotal. I've had patients come in, they love it. They see rounding of their face, rounding of their breasts. They see better mood, better libido on it. But then some patients come in and now they have increased body hair. Maybe their mood swings are fluctuating more. So it's really up to the patient. I don't typically start this day one. I say, let's get you on the estrogen and your testosterone blockers, and then we'll go from there. So as far as monitoring, you really just are trying to get their levels within the physiological levels of a typical female. When you're doing your labs, be very cautious with what looks normal and what looks abnormal, because if they're still in the chart as male, it's going to be showing male levels for estrogen and testosterone, and it's going to say it's abnormal. So the biggest thing is just being aware of what normal for the cisgendered counterpart is, and that's what you're aiming for. Their levels will not correlate with their degree of transition. So higher estrogen does not mean more feminization. So that's the biggest thing that you have to look out for. Everybody's going to be different, but just pushing their numbers isn't going to make them more feminine or more masculine. As far as transgender care, the Endocrine Society really recommends getting that testosterone below 55. But again, if they're using their natal organs for sex, sometimes this leads to the sexual dysfunction. And so just kind of keep an eye out for that. As far as monitoring, and this is what's recommended, again, by the University of California, San Francisco's guidelines, I typically will go every 3 months for the first year of their transition, and as long as their levels are stable and we haven't adjusted any hormones, I will transition them to every 6 months. But even every year is suitable. I think the biggest thing is, your patient's risks. Are they going to come back? Things like that. So I'll go every 3 to 6 months. If I do change their hormone, I will see them back at 3 months just to make sure that we're getting the goal that they want. Again, special considerations, just keep an eye out for your smokers. When you start an estrogen, now we're definitely increasing that risk for blood clotting. You can consider an aspirin 81 milligrams if you want to, but there's no data, so this is all, just, maybe it'll help. Biggest thing is, counsel cessation. This is not an absolute contraindication, but just stress the importance. I always tell my patients, if you develop a blood clot or if you have a heart attack or stroke, we have a very serious conversation about continuing your hormones. And so a lot of times that's enough to kind of make them want to quit because they don't want to have to stop their hormone. There is a list of kind of blood clot guidelines as far as provoked, unprovoked in these patients on the University of San Francisco or California San Francisco's website that you can reference if you need to, if your patient does have a clot. Again, watch out for the erectile dysfunction. You can use sildenafil and tadalafil, no problem in these patients. That lower libido, this again, higher risk in trans females versus trans men, but again, not correlated with their testosterone levels. After they have a gonadectomy, so after they have the orchiectomy, you really don't need to lower the dose, but you may want to start monitoring the LH and FSH, mainly for the bone health. I have not done this yet, for the record, but I only have a couple patients who are post-gonadectomy. But they are old enough for DEXA scans, and so that's why I haven't monitored the hormone levels. But also watch out, there is an increased risk of autoimmunity. Testosterone has been shown to be protective as far as autoimmune diseases are concerned. So when you're blocking that testosterone, you may see a higher incidence of autoimmune disorders in these patients. So just kind of watch out for those symptoms. As far as transmasculine hormones, once you start testosterone in these patients, these are the changes that you're going to start to see. So you're going to start to see definitely more acne, more skin oiliness. You'll start to see the facial and body hair, which is desired for them. Scalp hair loss, depending on the patient. Some men find it masculine, looks good, and then some people hate to lose their hair. But the biggest thing, again, cessation of menses is great. You will see some bottom growth, but again, the degree is variable. Deepening of the voice is wanted, but they may come in complaining of vaginal atrophy or vaginal symptoms, UTI symptoms. So that's something to just kind of keep an eye out for. So again, their transition starts a little bit quicker. A lot of times you'll see some changes in the first 1 to 3 months, really 6 months again for that max, big initiation of hormones or side effects really. But then they hit that maximum transition around 2 to 5 years where they start aging naturally at that point. Voice, people always ask me all the time, well, how deep will my voice get? I say usually look at your voice at 1 to 2 years, and that's about where you're going to be. So first, as far as testosterone goes, there is testosterone cypionate, testosterone enanthate. I don't know how to say that one, I'll be honest. Testosterone gel, and then pellets. So typically injectables are the way that you're going to go with these patients. There is a transdermal gel that you can use, but injections usually are the way to go. The question is, subcutaneously or intramuscularly, they work the same. The testosterone ethanate is more of a sub-Q injection. It can go IM, but testosterone cypionate is typically branded for IM use. You can inject it subcutaneously. The pharmacies sometimes could, get a little upset with it, but just prescribe the shorter needle. So typically I start everybody on 0.5 mLs, and so what that means for these patients is about 100 milligrams a week when you're doing the testosterone cypionate. And then, so I start everybody on the standard dose, and then when they come back at 3 months, I'll titrate up or down based on their levels. I try to keep testosterone levels in the 400 to 500 range. I really try not to go super therapeutic just because of the risks. You can go every other week, or you can go twice a week at smaller doses. Again, there's no standardized regimen, and so I think the biggest thing is finding a good starting dose and then adjusting it up or down from there. So again, route of administration, like I said, IM and sub-Q has the same efficacy. It does not matter which one you do. I think the biggest thing with subcutaneous is it doesn't hurt as bad. It's a smaller needle, so it's a little less scary. There is an auto-injector that you can use for the testosterone ethanate. It is branded. So a lot of times trying to get it approved by your insurance is a little bit harder because it's only approved for hypogonadism. So I will use that diagnosis code when I'm prescribing it because technically my transmasculine patients are hypogonad. But again, it takes a lot of more hoops to jump through when you're getting that branded, but it has been helpful with the auto-injector. And then as far as proper use of the transdermal gel, typically I like my patients to use this first thing in the morning. You can really only apply it to your upper arms and shoulders. I'm sure patients have put it somewhere else, but we don't know how well it works when you're putting it other places. You want this area to remain dry for at least 2 hours, and you really want to avoid contact with other people in that area, so like hugging, whatnot. That you don't want them to be exposed to testosterone, so specifically women and children. After that 2-hour time frame, you can wash the site, and that will help decrease that risk of the exposure, but not affect your absorption rate. As far as fertility considerations in transmasculine patients, cross hormones are not birth controls, and this is really in trans feminine patients as well. If they still have some sperm, they could potentially get somebody pregnant. So these are not birth controls. So make sure that you're talking to your patients about birth control options, whether that's an IUD, the implant into the arm. Usually progesterone-only birth controls are preferred because they're not going to get the estrogen. And then obviously barrier methods with your trans feminine patients. As far as puberty goes, so what we're seeing, especially so far, there's still not a lot of studies, but if you start suppression kind of at that Tanner stage 2, and they don't actually go through puberty, they're not really developing mature oocytes that we're seeing, or really oocytes or sperm. But the biggest thing is, if they may want to have a genetic child later in life, which at 15 or 13, that's a hard conversation to have, you may want to start, suppression a little bit later, or even not suppress at all. Again, there's a lot more studies undergoing, so I'm sure, in years to come, we'll have more information. But transgender adults have gone on to have their own children. Fun fact, they call trans males who have babies seahorse dads, because seahorses, the male carries the baby. So so they'll use that term a lot. So they can have genetic children, but just think about this, especially with teenagers, these are not birth controls. And again, as far as monitoring transmasculine hormones, same thing. You want to try to hit that physiologic level of a male. Their levels will not correlate with their degree of transition again. Again, you just titrate based on how they're feeling, what their numbers are, and really just the safety as far as polycythemia, liver function, et cetera. We should see amenorrhea by 6 months, hopefully. Really try to get that estrogen level less than 50 if you can. But again, they may still have cyclic symptoms, so keep an eye out for that. You may have to change which route you're going. So again, every 3 to 6 months, depending, and then even yearly once they've been on hormones for an extended amount of time. Same thing with these patients post-oophorectomy. You do not need to reduce their dose, but watch out for that erythrocytosis, that polycythemia. So always monitor their H&H levels, especially now that they're not having periods. They're definitely potentially going to increase that H&H. You may want to consider switching to transdermal if they are having a lot of polycythemia, but also if they're having polycythemia, don't just blame the testosterone. Make sure there's no underlying causes. I think that's something that's really important. Phlebotomy is just a short-term fix. It's not, again, don't just say, hey, this is your testosterone. If their levels are staying high, sure, they can go donate blood, but then try to figure out why. Is it their type of testosterone? Is their dose too high? Or is there an underlying condition? So just think about that as well. As far as hair loss, you can use minoxidil or a 5-alpha reductase such as finasteride or dutasteride. Anecdotally, some of the 5-alpha blockers has caused menses to return. So again, that's anecdotally. I don't know if that's statistically, but a lot of my patients have come back after finasteride with their period again, and so they asked to switch to minoxidil. You can do oral for both of these, or there are some topical ones that have come out. I'm sure you've seen things like Hims and Keeps with the topical mix of the both. Some local compounding pharmacies are also doing this. So that's an option. There's also surgical approaches. They can go get hair transplants, et cetera. But also watch out for different metabolic syndrome in these patients, or even related conditions like PCOS. That can still become a problem. And then as far as surgical transition, again, I'm not a surgeon, so I'm just trying to make you more aware of what surgeries may be out there. So your job as the provider is essentially to make the appropriate referral. Tennessee has the gender clinic at Vanderbilt, which I think is really helpful for patients. Most of my patients will go there. Some will still go out of state. I always tell them, any surgery that you have in life, you want to feel comfortable with your surgeon. So if I make a referral somewhere and you don't like the surgeon, go talk to somebody else, because you're going to be going under the knife. You want to be comfortable with who's going to be putting you under and the results that you're going to get. As far as genital surgeries go, we really don't do these until after the age of 18. Sometimes it's for just, you want, especially for trans feminine patients, you want that more penile growth allows for more tissue for the surgery. If any surgery is going to be done in a pediatric patient, it's usually that top surgery that we heard about yesterday. That happens because, again, they want to go to the lake with their friends and not have to bind or wear a rash guard. They want to be able to take their shirt off. So that's really the only surgery that's done early, but there is a lot of documentation that goes behind that. So for feminizing procedures, biggest ones that you're going to see: laser hair removal, silicones, fillers, liposuctions, facial feminization surgery, breast augmentation, and vaginoplasty. The biggest one that I kind of want to caution you on is the silicones and fillers. Patients will go and get these done kind of, I call them back alley type of ways. I have a patient that just got back to me. She said that she went to her friend's house in California and they injected it in the living room. So on one lookout for signs of, infection. A lot of times with these silicones and fillers, they can migrate, they can cause a lot of deformities. There's a really big case on Botched about a lady who did a lot of fillers back in the 60s, 70s, and now had a lot of deformities. So just kind of look out for that. But those are the ones that you're going to see. As far as the laser hair removal, a lot of times it's just finding an esthetician. Some dermatologists may provide it, but trying to get that one medically covered is a little bit harder than like the liposuction and the FSS and the augmentations. So this is what a vaginoplasty typically looks like. Again, I'm not going to go into super detail, but it's color-coded for you so you can kind of see what becomes what part. I was kind of excited to see it, not excited, but just that nerd in me. Embryonically, we all start out kind of female in womb, and then based on what hormone we're exposed to is how our external anatomy develops. And so they're essentially taking that external anatomy as far as this is concerned, and then they're kind of reverting it back to the female embryological equivalent, which is kind of cool. So really the first step is to kind of take that penile tube off, or to form a tube from the penile skin. They separate it from the corpus callosum, the nerves, the blood vessels, etc. And then they make a slit within the scrotum. From there, they take their scrotal stent, they extend the tube. This will eventually become the vagina. The corpus callosum is removed. The nerves are left to the glans, but the glans is debulked a little bit. This will become the new clitoris. From there, everything is kind of turned inside out, is the way I like to say it. It's tucked in between the bladder and the rectum and tacked up. The clitoris is put in position, and then they close that scrotal skin to make the labia majora, and go from there. So again, I'm not the surgeon, so my terms are not the best terms to use, but you can kind of see what's happening. Just want to make sure there's nothing else to touch on. The biggest thing with these patients that you may run into is they do require dilation of the new vagina, and so they may have stenosis, which may make sex painful, things like that. So just make sure that they're doing their dilating if you see them post-op. And then if they start to have any stenosis, you can try some estrogen creams, but a lot of times it's trying to get them back to their surgeon before too much stenosis happens. And then real quick, the masculinization procedures, again, hair transplants, some facial masculinization surgeries. That top surgery or mastectomy, which we learned yesterday, is not risk reducing. Hysterectomy, bilateral salping, ejectomy, oophorectomy, and then metoidoplasty, phalloplasties, and even erectile devices. So the most common top surgery that you're going to see is a double incision or a peri-areolar. This really just depends on how much breast tissue they have that they're going to be a candidate for. You may even see that inverted T, which we typically see with most breast reductions in a cisgendered female. So just kind of keep an eye out so that you're just familiar with what their scars may look like. Some will do nipple grafting, some will not do nipple grafting. It's just one more thing that I can say possibly could go wrong during their surgery, but one more step of their healing. So just watch out for like graft rejections and things like that. And then a metoidoplasty, really they're just they're releasing the ligaments around the clitoris, allowing it to drop further. Some will do a vaginectomy, some will not do a vaginectomy, so they have to have a hysterectomy before that. But it just allows kind of like a small micro penis. They can do urethral lengthening through this. Again, some will, some won't. Everybody's going to be different, but just so that you know what a metoidoplasty is. And then, of course, the phalloplasty. So this is just a forearm flat phalloplasty where they take a graft from the forearm. They will also take a piece of that skin, invert it. That becomes the new urethra. It's often done in stages. So this is showing the phalloplasty with a... Let's get this. So this is where where their new urethra is going to be for right now until they go back and connect it. But again, some people will just do phalloplasty with no vaginoplasty. Everybody's going to be different depending on their surgeon. If they do a vaginoplasty, they can do a scrotoplasty as well with testicular implants. They will connect the urethra so they're able to stand to pee. And then they can also go and do the erectile implant afterwards. So obviously there's a lot more. These are my two favorite websites. The University of California, San Francisco Transgender Care website is, if you have questions, you can go to this website and they will lay it out for you pretty much step by step. It's due for an update this year, so there's a lot of updates kind of coming to that website, but also the WPATH, which is the World Professional Association for Transgender Health. If you provide gender-affirming care, you can actually register with this organization. And if if patients are looking for a provider, they can access the WPATH and find a list of providers. It's not the most user-friendly website, so I will go ahead and tell you that one. I'm not even on it because I haven't really figured out how to do it. So that's something that is my goal in the next year, is to try to navigate that and get at least myself listed on there. But again, this is why I do what I do. I am actually a transgender male. I started my transition my 4th year of medical school. So this picture was my first year, right before my white coat ceremony. But it's something that, as a kid, I was very insistent, persistent, and consistent. I always told my parents, I'm a boy, my anatomy is going to grow. I wanted the red bike, not the pink bike. And it just kind of stuck with me. I think during grade school, I reverted back to my birth name and identifying as female just because we didn't know what transgender was. But it's something that never left me. Eventually, I identified as a lesbian. And that didn't sit right. I didn't like being called a lesbian, probably because I didn't identify as a female, internally. And then once I learned about transgender, I realized that that's kind of who I was. And so I started medically transitioning. I'm 7 years on hormones now. So that's about it for me. But this is why I do what I do and why I provide the care. I think it's really great when your patients can kind of see themselves, in their provider. So I guess any questions? Yeah.
What's the average, financial burden?
The average financial burden, as far as hormones go, now that we have GoodRx and cash prices, you can typically get most hormones covered for less than $70 a month cash price, depending on where you get the testosterone and what you're utilizing is what I've seen. But usually less than 70 if you're working it kind of the right way. As far as surgeries go, top surgeries can range anywhere from $5,000 to $10,000. Just had a patient do a cash price top surgery at Vanderbilt, and it was about $9,000 because their insurance wasn't going to cover it. But somebody like me, my surgery was covered 100% by insurance. My top surgery was. So everybody in their insurance is different. So it's just helping them navigate that. Anything else? Got one in the front.
I guess that was going to be my question, was insurance. Have you seen any rhyme or reason, different plans, what kind of causes insurance to pay for some of this and then some insurance is not?
I haven't identified any plans. I can't tell you that this Blue Cross Blue Shield or this United Healthcare is going to cover it. It's all very, very different. A lot of times it's how you word it. So I try to avoid sending my medications under gender dysphoria because their insurance is going to see that, and if they don't cover gender affirming hormones, then they're just going to deny it right away. So I try to use gender dysphoria like in my note, but then I send everything under hormone replacement therapy, which tends to hide it a little bit easier for my patient. Sometimes I go back and find out that if I would have sent it under gender dysphoria, it would have been covered. So I think it's about just it's a lot of prior authorizations, a lot of peer-to-peers, but most of the time I can usually get it covered. But if not, I just send them to GoodRx, and you're looking at, $20 or $30 for testosterone cypionate. So I think it's a lot of just setting expectations with your patient and figuring out what they can do. The other thing that you can do, depending on your office, we offer injections at our office. They have to come weekly. The downside is the injection fees usually at our office about $45 to $50, and then the cost of the medicine, which is I think like $7 an injection or something like that. So that's another way that you can mitigate it, is offering it at your clinic too.
So I guess before you start replacement therapy or really go down that road of discussing it, what's kind of the build up to that? Do you have to get like a psychology clearance type of thing? Because I mean, we even have to do that for bariatric surgery. So it's, I don't know what that process looks like necessarily.
Yeah, so that's kind of what I talked about briefly, like with far as like the referral letter versus informed consent. Like if they go to Planned Parenthood and they say, I'm transgender, I want to start hormones, they really just get talked to about, these are the risks, the benefits, and then they say, I understand, and you can move forward. It's really up to you. For me, as a trans male, I prefer to have the letter because I never want someone to transition and then later detransition and say, "Why I only did it because Dr. Peacock is trans." He felt, he made me feel that, So I do it for my protection as a trans male, but like I said, I do a mix of both. You do not have to have a psychology referral. Even that online source that I talked about, the Plume, they'll meet with a psychotherapist like once. It's not required. Personally, I had a lot to work through. I had some family stuff that I knew was going to take a turn when I transitioned, and so therapy for me was really important, and so I had a letter. So I think, and so that's why I ask these questions, like what does your social life look like? But it's really what you're comfortable with as a provider. But if there's a lot of mental health and things like that first, maybe I won't start hormones right away until that's more stable, because you don't, but then you also risk worsening their mental health because they're not transitioning either. So it's finding what feels safe for you and your patient.
So you were talking about the younger folks getting a good history from them about blood clotting disorders and, kind of family history stuff, if they had had tumors or anything. But I mean, in my experience, they never know.
Yeah.
Like the younger crowd never knows their family history medically. They're just like, oh, I'll have to ask mom or, you know. So how do you really get a good, accurate history as far as that goes when they usually know nothing about their family history? Yeah, I think the biggest thing is, how do you get an accurate history from anybody? If they don't know or they didn't ask. But I think the biggest thing is, if they say, well, my dad had testicular cancer or something like that, then that might become more apparent. So if you can find it, great. If you can't, just make sure that you're talking about screening and things like that. You still want to examine the organs that they have on the routine basis. So if it's a transmasculine person, you still want to do their pap smear starting at 21. You still want to do an internal X. So you just do the best you can. I don't think there's a good way to suss it out or not. But if they have a clotting disorder, maybe meeting with a hematologist or something like that, how can I decrease their risk of clots or provoked clots at this point? Wish I had a better answer for that one. So, yeah. Any other questions? I'm around all day, so. Awesome. Good.
So we'll start back at 8 o'clock if you want to take a short break. So next is Dr. Jessica Chandler. She specializes in minimally invasive gynecologic surgery with an expertise in endometriosis and other complex gynecologic conditions. These include advanced laparoscopic procedures and robotic-assisted laparoscopic procedures. She completed a 3-year advanced laparoscopy fellowship through the American Association of Gynecologic Laparoscopists at Virginia Mason Medical Center in Seattle. She currently works for the Permanente Medical Group in Stockton, California, as a complex benign gynecologic surgeon with a focused practice on patients with endometriosis, pelvic pain, and uterine fibroids. She also works with women that desire hormone therapy for the treatment of perimenopause and menopause-related symptoms. Dr. Chandler is an inaugural class graduate of LMU-DCOM. Please help me welcome Dr. Chandler.
All right, good morning, everyone. How are we doing today? Good, great. I'm going to tell you right now, my body wants to know why I'm up at 5 a.m. talking about menopause. And they're like, this is way too early. Yes, you're passionate about it, but this is not the time for us to get up to discuss this. So with that being said, I kind of want to go back a little bit because I want to hang out here on this slide. And before we do that, I want to know who I'm talking to in a room. So how many of you practice adult family medicine? Raise your hand. Okay, great. Keep your hands up for me. How many of you practice internal medicine? Okay, internal medicine, fantastic. Everybody keep your hands up. Keep your hands up. How many pediatricians do we have in a room? Okay. How many surgeons do we have in a room? Any GYNs, okay, orthopedic surgeons, vascular surgeons, fantastic. Students, residents, everybody keep your hands up. This is an active participation lecture. If I'm going to be up, you're going to be up, okay? Students and residents that are interested in being in any of those specialties that I just called out. Okay, if you look around the room, the majority of you have your hands up. And the reason why that's important is because this topic that I'm going to talk about is going to be pertinent to your practice. So I just wanted you to know. So everybody, tune in. My interest in menopausal medicine actually began when I was in fellowship. A number of women were coming to us. They were wanting their ovaries removed, or we needed to remove their ovaries, whether it was because they had advanced stage endometriosis or their fibroids had completely encompassed their ovaries and there was actually no way to salvage them. And as a result, we had to do some form of hormone replacement therapy. It is not ideal to be 45 and having hot flashes every day, because you had to have your ovaries removed when you had your hysterectomy. And so that's where my desire to really study this topic and learn about this topic came about. That's how I ended up getting my certification through the North American Menopause Association, which is now known as the Menopause Society. And ultimately what I realized was, man, a lot of women are walking around in menopause. And because we're living longer, a woman is actually going to spend about 1/3 or close to 1/3 of her life in this menopausal phase. So knowing how to treat women in menopause is going to be very important. But what I want to talk to you today about is actually about the cardiovascular risk associated with perimenopause, because guess what remains the #1 killer of women? Cardiovascular disease. So here we go. I have no financial disclosures, just here because I'm passionate and I love doing this. And as we talked about, some objectives for you all this morning is to identify the patients that are in your practice that have a risk for cardiovascular disease, and also calculate what that risk actually is so that you can have a conversation with them. And we're going to use those tools to determine, well, what type of therapy can I actually provide you with? And we'll talk about how providing patients with hormone therapy can actually alter some of their risk. So the majority of you in the room are going to face this next patient. This patient is in your practice. You may not know her personally, but if you are a patient-facing healthcare provider, you definitely know her story. She's about 47 years old. She's got 2 kids. She's coming in to see you because she's complaining of fatigue, irritability, and irregular periods. And you get a little bit of a history from her. And what you begin to find out is that the reason why she's so tired is because she can't sleep at night. And the reason she can't sleep at night is because she's waking up in the middle of the night having hot flashes. And she is wondering, well, what can we do about this? Because it's interfering with her life, and it's really annoying. She thinks she's going through menopause, but not quite ready to accept that just yet. And she really wants to know how long it's going to take. And as you talk a little bit more and you obtain that history, what you realize is that her periods are getting further and further apart. So instead of her cycles being every 28 days, her cycles have kind of progressed from being 28 days from the first time she bleeds until the next time she bleeds to 34 days. And 34 days are now progressing to 56 days. And she's taking multiple pregnancy tests, although she doesn't think she's pregnant, but she hasn't had a period in 56 days. So if you were in John Williamson's class, you learn, is she pregnant, is she infected, or does she have cancer, right? But she had both of her fallopian tubes removed, so she can't be pregnant. So what is actually going on? These are the women in our practice. We just have to talk to them and get their information. So this is a staging system. It's referred to as the staging system of reproductive aging in women, known as the STRAW 10. There's 7 stages that are going to range from menarche to their reproductive age. And today my focus is only going to really be on 2 of these stages. We're going to talk about the early and late stages of the menopause transition. What do we know about the menopause transition? Well, we know that it all begins there. And when I say it, I'm talking about their risk for cardiovascular disease. We know, like I said, I'm going to adjust this mic. I'm really trying not to move. You all have no idea how much I just want to walk throughout the front, but the tech guys have asked that I not do that. We know that a woman's cardiovascular disease risk is going to actually start around this stage, but we also know that in postmenopause is where we're going to begin to see those conditions really manifest. And what they've hypothesized is that the transition or the increased risk actually is going to happen in that menopause transition. So back in 2000, the American Heart Association started a longitudinal study in which they were following people, following women specifically, and they wanted to know, what does a woman's life look like? What does her risk for cardiovascular disease look like? And they released that data in 2020. Now, we were all a little preoccupied with other things in the medical community in 2020, so we may have missed them actually releasing their scientific statement, but that's the reason why I want to talk to you all today, because I want to make sure that we're aware that this is a real issue, and it is something that we need to be screening our patients for, and it is something that we need to be making sure that we are addressing when they come and see us in our practice. So, the thing that happens before a woman goes through her menopause transition, she's actually in her reproductive years. So for those of you who do obstetrics, any obstetricians in the room? No obstetricians in the room? Okay, there's some obstetricians online. I don't practice obstetrics anymore. I don't know if you all caught that from my bio. I got out of that world as quickly as I could because I realized that was just not for me. Because every woman deserves an obstetrician that is dedicated and loves what they do. I didn't enjoy it. I enjoy being a gynecologist and I enjoy practicing menopausal medicine. But for those of you who practice obstetrics, this patient is in your practice. She's 31. She's a G1, P1. She and her husband are not quite sure if they're done having kids. In her pregnancy, she ended up with gestational diabetes, and towards the end of her pregnancy, she developed preeclampsia. She's concerned because her doctor told her not only will she potentially develop diabetes again in her next pregnancy, she may also develop preeclampsia. But, and here's the thing, she will likely have problems with her blood sugar as well as her blood pressure throughout the remainder of her life. So, these are the reproductive risk factors for cardiovascular disease. And the Menopause Society put out a practice pearl for reproductive risk factors for cardiovascular disease in women. And basically what we have learned is that adverse pregnancy outcomes such as preeclampsia and gestational diabetes increases a woman's chances and risk for cardiovascular disease. What we know about the hypertensive disorders of pregnancy, such as chronic hypertension, gestational hypertension, preeclampsia, and eclampsia, we know that they are all independent risk factors for the development of cardiovascular disease, even after you adjust for other adverse pregnancy outcome risks, such as low birth rate, as well as preterm birth. And when it comes to the hypertensive disorders of pregnancy, there's also a severity. So if a patient has chronic hypertension, their risk of cardiovascular disease is going to be a lot less compared to that patient that maybe has preeclampsia, or maybe that patient that developed preterm preeclampsia. And some of you are just like, Jessica, this doesn't pertain to me as a family medicine doctor. But oh, it does. Please hold on. And what about gestational diabetes? Well, we know that having gestational diabetes will increase your risk for diabetes by 7-fold. And then we know that it's going to increase your risk for cardiovascular disease by 2-fold. But that risk for cardiovascular disease in women with that history of GDM is independent of them actually developing diabetes. So they may not even go on to become a diabetic, but that risk is still going to exist. And why is that? Well, they did another study. The Cardia study is what you may find it under if you look it up. And when they evaluated those patients, what they found was that just having an elevated blood glucose level and having that gestational diabetes, it is going to lead to the development of cardiovascular disease or coronary artery disease by pathways of that insulin resistance, which is going to impact their underlying vessels. And that impaired insulin sensitivity is even going to be present if you have a patient who maybe doesn't go on to become a gestational diabetic, but maybe they have some insulin insensitivity. And so when I'm talking to my patients and I'm asking them, so what was your pregnancy like? Tell me about it. You know, I'm taking their history, right? I'm thinking about these things, and they may say, oh, I had a little problem with my blood sugar, but I didn't have to be put on medicine for it. I'm like, oh, okay. Did they tell you that you needed to control your diet and watch what you eat? And they were just like, yeah. And I'm like, okay. And they'll make a little note of that. Or if I ask, did you have problems with diabetes in your pregnancy? Did you have an issue with your blood pressure? And kind of parse that out. Because again, depending upon what they had, it is going to impact their overall risk. Excuse me. So how do we obtain this information? Well, if you were paying attention, you know what my next slide is about. Does anybody know who these gentlemen are? Martin, I know you know. Elizabeth, I know that you know. We've got a few hands here. Dr. Howard Teitelbaum, Drs. Howard Teitelbaum, and Dr. Burt Routman. And these were great faculty. Again, I was a part of that inaugural class. They, along with other members of the faculty, they taught us how to obtain a history. And what they taught us, they said, if you allow a patient to talk long enough, they will tell you what's wrong with them. And that skill set of being able to obtain a history, I don't care what your specialty is, it never goes away. It is always going to be helpful. The majority of what I do in my practice is I do surgery, and so I see women who need to have surgery. And so understanding their history is not only important to how I'm going to counsel them on how they get ready for surgery, but also how I'm going to take care of them after surgery. And if they're going to come back and see me for their menopausal management, how I'm going to take care of them afterwards. And so for those of you who may be viewing this presentation for students or residents, one of the things you're going to learn is that as you kind of grow in your career and as you begin to specialize, the histories that you're going to begin to obtain are going to be very narrow and very focused for what you do. I would be very surprised if someone who's doing orthopedic surgery is going to ask a woman, well, how many babies did you have? And what was your pregnancy like? Tell me about your OB history. I'd be real surprised if an orthopedic surgeon who's going to be doing your hip replacement asked you about that. But this is important. And what I would like for us to get into the habit of doing is taking what I like to call a cardiovascular health history. So, American Heart Association have come up with what they call the Simple Seven. Now, for those of you who are paying attention, you know that there are not 7 bullet points on this slide. Don't worry, we're gonna get there. But what they are doing is they're classifying a woman's cardiovascular risk based upon the Simple Seven. And they break it down to ideal, intermediate, or poor. Now, the 2 that I'm gonna focus on, not those 2. I told you this early. These 2. We're going to focus on blood pressure and fasting glucose for some of the reasons that I just alluded to. But not only that, we know that these are things that are going to impact our overall cardiovascular risk. When it comes to blood pressure, we know that having a systolic blood pressure increase of anywhere from as low as 10 millimeters of mercury can increase your cardiovascular risk by 15%. So just a 10-point jump increases your risk by 15%. That's not just for women, that's for men also. So keeping blood pressure under control is key. And some of the ways that I talk to my patients about doing that is actually encouraging them to follow certain eating plans. Now, we've maybe heard of the DASH eating plan. I don't like to refer to it as a diet because when I think of diet, I think of limits, as in I'm gonna start my diet on this day and I'm gonna end my diet on this day. And really what I try to encourage my patients to do is think about this as a lifestyle change. Not something that I'm gonna do to get ready to go on vacation or so I can get ready to fit into that outfit for that special event, but ask yourself, how can you begin to make lifestyle changes? Lifestyle changes are hard. Because it's not just a matter of me saying, oh, I'm going to, eat less of something. It is, I'm going to limit this, but I also need to replace it with something that is better for me. It's not just, oh, I'm going to eat, not a bowl of ice cream after dinner. Maybe I'm just going to have 1 scoop of ice cream. And when it comes to food, it's not just a matter of, oh, this is what I'm putting on my plate. Sometimes it's really, well, this is what I have access to. And depending upon where you practice, as much as we want our patients to eat more fruits and more vegetables, they may not have access to fresh fruits and fresh vegetables because they may live in the middle of a food desert. And so they don't have access to that. And this is where those history-taking skills that we, obtain from sitting in those classrooms with Dr. Heidelbaum and Dr. Routman and Dr. Whiting and Dr. Seaman and all the patients or all the professors that were a part of our education, our learning, that's where it comes into play because now I need to have a conversation with you. And I need to understand what are the barriers that are going to keep you from being able to make these changes. And how can I, as your healthcare provider, partner with you to help you make these changes? So you may not have access to fresh fruits and fresh vegetables, but is it an option to maybe get the 2% milk or the reduced fat milk instead of getting the whole milk? is it an option to maybe get more beans and less starchy vegetables? How do I work with you to help you make these changes? Because the other thing, and this is where all of us, regardless of our specialty, a lot of our eating habits and a lot of our patterns and what we do, it starts when we're young, right? It's what we grow up with. It's what we're exposed to in our home. So for those of you who are pediatricians, talking to not only your patients, but talking to your patients' parents to say, hey, how can we introduce small changes so that if we do these over time, we now build more habits, or we build better habits or different habits that are actually going to be beneficial. Because what we're going to see is that this is truly a spectrum. It's not just one part of a patient's life. It is what happens during her, developmental years and her prepubertal years that impacts what she does when she is pregnant, right? Because during pregnancy, there's an old adage, well, I'm eating for two. Not really. You're not really eating for two. You're eating for yourself. Baby's gonna take what baby needs, but also what you're eating is gonna impact baby. And so now we deliver baby comes home. Well, how you continue to eat is going to impact the baby that's one day going to become the child, that's one day going to become a teenager. And if it's a girl and she decides that one day she wants to have a baby, it just kind of goes so forth and so on. So partnering with your patients to help them make those lifestyle changes is important. And if we think of it from a long game perspective, that's what we want to do. So there's an eating plan to help reduce high blood pressure. But what about blood glucose? The goal is really to get a patient so that they're normal glycemic. And when it comes to women who are interested in becoming pregnant, or individuals that are interested in becoming pregnant, if we can get them to enter into pregnancy at a normal glycemic level, they're going to do a lot better. And there are a number of ways to do that. Again, depending upon where that patient is at, kind of on that spectrum of physical activity, access to food, and access to fruits and produce, I will just encourage them. I will say, can you just do me a favor? After you get up from the table, after you get done with your meal, can you go and can you walk for like 10 or 15 minutes? Just go take a walk. If you have the ability to take a walk and maybe pump your arms, move your arms, do something to get more muscles involved, your muscles are going to say, hey, blood, we'll take that glucose. And as that glucose gets pulled out of the blood, that blood glucose level is slowly but surely going to begin to go down. Also, getting them into the habit of physical activity is building a different habit, is introducing a different activity, lifestyle. Hopefully, it'll encourage them to begin to become more active because hopefully they'll begin to feel better. One of the things that I'm not going to have enough time to get into today, but just the role of physical activity and our mental health, sleep, and the role of sleep in our cardiovascular health. But there's a lot of benefits that can come from just getting into the habit of going for a walk for 10 to 15 minutes after each meal, or as your schedule will permit. And that's what it's about. It's about meeting these patients where they are so we can help keep them around longer. And not just keep them around longer, but keep them around with a quality of life that is actually productive. I say that because today is my grandmother's 91st birthday. Grandma, I don't know if you're going to see this, but happy birthday. She's 91, and she is a very active 91-year-old. And I look at her and I'm like, oh my gosh, you're 91? Someone at the DMV thought it would be very funny, and so they allowed her to renew her driver's license last week. And I'm like, okay, no one in the family owns a vehicle that you can see over the steering wheel, but you're 91 and you have your driver's license. But she's 91, she doesn't have any chronic medical conditions. I think she's on the lowest dose of a cholesterol medicine because her doctor just felt like he needed to do something because she was 91, right? Very different than some 70-year-olds that I know that have had a stroke and they have diabetes and their mobility is very limited. So quality of life is an important thing. And we have the opportunity as osteopaths, because we have this training, to meet our patients where they are and consider them as a whole person to help them make these changes that are going to be sustainable throughout life. So what about hormone therapy? You weren't going to get a menopause specialist up here to not give a lecture that was, not going to include some things about hormone therapy. A lot of people are afraid of hormone therapy, and you shouldn't be. Yes, the WHI came out, several years ago, and it scared us all, and, women were taken off of their hormones because we were concerned that it was going to cause breast cancer and cause a number of different things. But when they went back and they did those studies in the appropriate groups of patients, what they found is a lot of the things that we thought hormones contributed to, they actually did not. Most of the women in our practice are going to fall in this intermediate risk. And understanding their history really matters. And what I mean by that is we have to ask ourselves what is this number? What is this ASCVD number? What is it all about? So this number is a measure of a patient's primary risk factor for developing ASCVD or atherosclerotic cardiovascular disease. We're going to come back to this chart in a moment, but how do we calculate this? So there's a number of apps out there that we may all have on our devices or have access to in our EMR. This is probably the one app that I use the most every single day. And so how does it work? Pretty much, if you were to take 100 women or men, and you put in their demographics, what this is going to give you is a calculation of the probability in the next 10 years of them having either a heart attack or having a stroke, okay? And just a little thing about this is only to be used for primary prevention. So if they've already had a heart attack or they've already had a stroke, this app is not going to be useful for you at all. And so you put in their information, and what it will tell you is what their actual, their current risk and their lifetime risk. But the thing that I also like about this app is that it also gives you an opportunity to talk about how you can reduce that risk by introducing specific therapies. So if you have a patient that has high blood pressure and you start them on a high blood pressure medication, it will also tell you what happens with their overall risk. And you can do that with each of the risk factors if you start them on a statin, if you get them to quit smoking, etc. Remember this lady? She was our 40-something-year-old with a couple of kids that was coming in because she was tired. What you learned more when you talked to her a little bit more was that how she gets through her day, how she fights her fatigue, is that she goes to her local coffee shop and she gets a 32-ounce caramel-flavored caffeinated beverage. And she has one of those every single day. Now, we can talk about how that is impacting her, overall risk for cardiovascular disease. But what would it look like if you put her on hormones? Because remember, she was waking up in the middle of the night because she was having hot flashes. They found that if you treat a patient's perimenopause, because hot flashes can start when they're perimenopausal, if you refer back to that chart, that graphic that I showed you at the beginning, if you treat their perimenopausal or their menopausal hot flashes, it will actually impact their quality of life. And so when I'm counseling my patients, I'll talk to them. I'm like, well, tell me what's most bothersome for you. Because again, they're usually coming to me because they want to be put on hormones. And when they say, if I could just sleep at night, I would feel so much better. Because if they sleep, they're not waking up the next day ready to, kind of go at everybody, right? We all know what it's like when we don't get sleep. We all know what it's like when we don't sleep well and we don't eat well. And so, hormones. So we have calculated their ASCVD risk, and it's given us a number. And if that number comes back and is less than 5%, you are able to place that patient on hormones. And this is specifically for estrogen. Estrogen, depending upon how it is delivered, can increase your risk of blood clots. It can also increase your risk for having some alterations in your lipid profile. But when you get that patient that has an ASCVD risk of less than 5, they can be on either oral estrogen or they can be on transdermal estrogen. Now, please remember, if your patients have their uterus, in addition to estrogen, they need some form of progesterone. Topical progesterone in the form of a cream or in the form of a gel is not adequate protection. I say that because sometimes patients will come to me and they have either been started on a topical progesterone and they're on a higher dose of some type of systemic estrogen, and that is not enough protection. So you kind of have to go down a pathway of evaluating any abnormal or irregular bleeding that they have and exclude any type of hyperplasia. I have seen that before actually lead to a case of endometrial cancer. So I just want to remind all providers that topical progesterone is not adequate protection when a patient is on systemic estrogen to protect them from endometrial hyperplasia. But because most of our patients are going to fall in that 5 to 10% risk, offering them systemic transdermal estrogen is an option. And so this comes in the form of a patch. I'm a huge proponent of the patch because it's easy. They can switch it out either once a week or they can switch it out twice a week. Some patients don't care for the patches because they may fall off or they may find that it interferes with them being able to participate in outdoor activities and water sports, etc. When that happens, I either encourage them we can either try a different patch because the adhesive based upon the manufacturer is going to change. Some of them will put some type of adhesive covering or dressing, or I give them the option of being on an estrogen gel. The reason why I like systemic transdermal estrogen regardless, unless, I have a pretty young patient and she doesn't have any cholesterol problems and I'm okay with her being on oral estrogen, is that I can leave them on this longer. There used to be some thoughts that once a woman reached 65, she had to come off of her estrogen therapy. And we have found that that is not necessarily true. What we need to do is have a conversation with them in which we talk about the risks, the benefits, and the alternatives of them staying on their estrogen therapy. And we have that informed consent. And for me, I follow my patients. I'll have them come back in and we'll just check in every 1 to 2 years so that I can make sure they haven't had any major changes in their health history. And really what I want to make sure of is that they haven't really gone from this category to this category. But I'm okay with them being on their transdermal estrogen. Also, the thing that I like about the estrogen patch is that it comes in a variety of dosage, so I have a little bit more flexibility than I do with the oral pill. Because estrogen isn't just good for heart health and it isn't just good for hot flashes, it's also great for our bones, because as our bones get brittle, and we develop osteopenia and osteoporosis. Now we're falling, now we've got to have hip replacement, and now our mortality begins to go up, and it just kind of builds on itself. So if I can keep you on estrogen and not have to worry about you developing a blood clot and not have to worry about you developing other conditions that will lead to more mortality and morbidity, I'm for that. And I have the flexibility to do that with the transdermal estrogen patch. Another thing I like about the estrogen patch is when I have my patients that are perimenopausal, they may not want to remember to take a pill every day. And because they're busy. They're in that, 40, something of life. And so they've got kids that they've got to get to soccer practice. They've got parents that they're having to take care of. They have the work trips that they have to travel for. And they don't want to remember to grab their bottle of pills. They just want to grab a couple of patches and go. When it comes to progesterones, I, again, take that history. And for some of those patients, if they're telling me I'm having problems sleeping, I prefer prometrium in those patients, so oral prometrium or micronized progesterone. You have to be careful with that because it is compounded in peanut oil. So if your patient has an intolerance to nuts, they cannot take that medicine. But the thing I like about it is a side effect of it is sleep. And again, having problems sleeping. So put your estrogen patch on the Monday, take your progesterone at night. I typically tell them to take it about 1 to 2 hours prior to when they plan on going to bed, and that are sleeping throughout the night because you're controlling their hot flashes, but you're also inducing some level of drowsiness. And now all of those things that she was coming to you about, the fatigue, the irritability because she wasn't sleeping, you've managed to take care of at least 2 out of those 3. Her abnormal periods, that's a different thing. Feel free to send her over to her gynecologist so that we can take care of that. But the Mirena intrauterine device is another great way to address that because when a woman is perimenopausal, she can still get pregnant. Remember how I mentioned our patient, she knew she wasn't pregnant because she had her fallopian tubes removed? That's an important thing to ask about because if they need contraception, how you take care of them medically from a hormone standpoint is also going to look different because pregnancy is still a possibility. And if she was someone who had gestational diabetes or preeclampsia in her pregnancy or any of those other conditions, getting pregnant may not be in her best interest. So understand how all of this is kind of big picture and it's encompassing now. That's why I wanted to know who was in the room so that I can let you all know that, hey, we're all going to be taking care of these patients. And another key for this slide is let's figure out how we can keep our patients out of this category. Because once you get to that 10 plus or that 10% risk of more, it can be really challenging to get back down to their intermediate risk. We're doing a lot of things, and chances are, if you're already there, you're probably on some medications, or maybe you should be. And so those lifestyle changes that we were talking about in the beginning, it becomes more important that we implement those, but we're probably going to have to introduce some pharmacotherapy as well. So this is why it all matters. So what's my ask for you all this morning? We see patients throughout all phases of their lives. And whether you're seeing the patient that is in the center of this photograph or you're seeing one of the women on either side, we all have an opportunity as healthcare providers to truly impact the trajectory of their lives and impact how they live their life moving forward and whether or not they live it with some level of functionality or if they're going to have some form of restricted mobility. So I would like for you to identify those women that are in your practice that have risk factors for cardiovascular disease and coronary artery disease. And you can do that by asking questions. Ask them about their OB history. Ask them what were their pregnancies like. Don't assume that someone else has done it because again, it just kind of, if it's not your normal thing, if you're seeing her, for hip pain or back pain, you might not think to ask, but just ask those questions. Put them in her health history somewhere, and if necessary, refer her back to her primary. And maybe let her primary know, hey, I had a conversation with Mrs. Smith. She came here to see me about her low back pain. But I also found out that during her pregnancy, she had preeclampsia and diabetes, or she, had gestational diabetes, and no one has followed up to do a screening to see if she's actually a diabetic. Ask those questions, identify them. And once you identify them, treat accordingly. So ask them, what can we do to help induce the lifestyle changes? Ask about the Simple 7. If they are overweight, let's figure out what we can do to help them get some of that weight off. If they have elevated blood glucose levels, let's figure out what we can do to get that under better control. Again, this is extremely important for our patients who are in that reproductive stage and age of life. A number of women will come into my practice, and again, they're coming in to see me for abnormal uterine bleeding, but they mention, I want to get this under control because I want to get pregnant. And what I find is that individuals, when they are ready to make that leap to become parents, that is when you have an opportunity to introduce to them the lifestyle changes that you need them to make. And that's where that screening tool comes in handy, because again, when we calculate their risk, if I could say to you, hey, you are at risk of having cardiovascular disease based upon X, Y, and Z factors, let's figure out what we can do to lower that risk, right? Individuals are delaying having families for various reasons, so it's not always going to be that 20-something-year-old that's coming into your office talking about wanting to get pregnant. It might be that 32 or that 35-year-old that's coming in. And having that conversation with them on what they can do to reduce their risk going into pregnancy so that they can have a healthier, more optimized pregnancy, that's what's important, because that is going to be an opportunity to get them to carry those lifestyle changes throughout. And then, like we talked about, we know that what happens in pregnancy can potentially impact what happens during their perimenopausal transition, which, whether you have babies or not, all women are going to go through that. So when you see them coming in, and I typically begin to focus on these conversations when they're anywhere from 40 to 45. The reason why the perimenopausal transition actually can start as early as 10 years before their final menstrual period. So don't brush off the patient that's coming in at 40, 41 saying, Doc, I'm having hot flashes. Probe that a little bit more. Ask her about her periods. If she's finding that her periods month to month are starting to consistently not be regular, and what I mean by that is that the variability is greater than 7 days, and she's having hot flashes, guess what? She's in her early menopause transition. I mean, I want to tell her menopause. I prefer to use the term perimenopause because we think of menopause as something that happens when we get old. And to tell a 41-year-old that she's getting old, that's not cool. As someone who's closer to 40 now than I was a couple of years ago, I don't like being thought of as an old. So having those conversations with them is important. Asking those questions, because that's when you want to start introducing those changes, because the cardiovascular disease is going to manifest once they reach the age of the woman that's in the center of this photograph. That's when we're going to begin to see the sequelae of the high blood pressure, the elevated cholesterol, the elevated blood glucose level. So again, this is something that impacts all of us, regardless of the specialty that we fall in. So don't be afraid to ask those questions. And please, please, please don't neglect starting hormones, because you would be surprised of how treating some of these symptoms can actually lead to a better quality of life, actually gives them the energy, because you have more energy to work out when you're able to sleep at night. And when you don't have hot flashes, you sleep at night. I keep going back to that because that is actually one of the most common reasons why a patient will come to see me. It is the fatigue, it's not being able to sleep. And then they say, and I'm starting to have hot flashes. And it just opens up this opportunity for me to talk to them about where they are in life. And again, I got that skill because I'm an LMU-DCOM graduate, and they taught us how to take a history. So that is all that I have this morning. Any questions from the audience? Got one question over here. 2 questions.
So I know you mentioned Moreno. One of the things I was wondering about, progesterone supplementation was Nexplanon, if you use that, like if you feel like that's a decent option?
Yes, so yes. When it comes to progesterone, I'll use either of those options. And I know that the Mirena is not the only levonorgestrel containing IUD, whichever one you have access to. The key is to get that progesterone to the uterus. And yes, the Nexplanon is also an acceptable option. Yes.
So, and then my next question was about the kind of modifying the ASCVD risk factors. Has there, I really don't know if this has been looked into or not, but you were talking about like women who have gestational diabetes and the fact that that just kind of on its own, I think you said doubles their cardiovascular risk, and then increases it, sevenfold for developing diabetes. So has there been any research as far as like, maybe they're euglycemic, but looking at a C-peptide to see if they're euglycemic, but like maintaining that level just with a lot of insulin and maybe going ahead and putting them on metformin or something like that?
I have not seen that research. Not going to say that it doesn't exist. I just haven't seen it. What I will typically do when I'm talking to those patients who have had GDM is, number one, I just like to make sure that they've had a recent hemoglobin A1C. And again, I'm asking about other things, because now it's like, okay, well, do you have any other risk factors for metabolic syndrome? That's not something that I talked about, but metabolic syndrome, polycystic ovarian syndrome, these are all things that increase their risk of cardiovascular disease. And so kind of going down that road to explore that's all free game. And for me, because I don't treat those conditions, I like to make sure that somewhere in their chart, so full disclosure, the group that I work with, our medical group, our EMR is all integrated. So I'm going to see all of their diagnoses, and I have the ability to kind of highlight in their chart that they have a risk for cardiovascular disease. And I'll just put a little note that the patient is at increased risk for cardiovascular disease based upon X, Y, and Z. Please follow whatever your, society's guidelines are for screening for this, but let's not have it, go unchecked. But to your point in your question, I have not seen the role that the C-peptide plays in that.
I actually have two questions as well.
It's 2 for 2.
So if you have them on an estrogen patch, are you saying that you still prefer doing the oral progesterone, or if they're on an estrogen patch, would you do like a transdermal progesterone?
So when it comes to the transdermal progesterone, the way that transdermal progesterone works, it comes in a patch. So the Combi patch is one, and I use the brand because that's the only brand out there that I'm aware of that actually contains transdermal progesterone with transdermal estrogen. So that is an option for some. It is expensive. It is really expensive, which is why I typically don't go that route. So I ask the patients, when it comes to progesterone, it's based upon what they need. So if they need contraception, I will offer them an intrauterine device. If they don't need contraception, again, are you having problems sleeping? If so, let's go with micronized progesterone. If you're not having problems sleeping, pick your progesterone. We have so many, right? But the progesterone is one that I kind of have a little bit more variability, and I'll kind of ask the patient their additional needs. But again, if they fall into that intermediate risk of 5 to 10%, transdermal estrogen is really my only go-to for them.
Okay. Yeah, you had just mentioned them not having to remember to take a pill with doing the patch, and so I was thinking, well, if they're on an estrogen patch, but they're still having to take a progesterone pill.
Yeah, and that's the trade-off, and that's where one of the intrauterine devices would be helpful. Which, let me also say that, again, if we're using it for contraception, great. If we're using it to help control heavy menstrual bleeding, great. And I just take advantage of it if it's there, if they need it. But yeah, the progesterone, that's the one where we kind of have to, I kind of say, okay, I can't give you any other form of progesterone because you may not need it, but a pill, and most women are okay taking that pill at night because, again, they're going to get the benefit of it, of them being able to sleep. So yeah, it's just that conversation as far as what's going to be best for you in your life and where you are right now and what you need.
My second question was about absolute contraindications. You know, you mentioned that a lot of providers outside of obstetrics and gynecology are fearful of starting hormones. So is there anywhere where you just absolutely draw the line and say no hormones, or do you just have a really in-depth, informed consent discussion and document that, they understand? Like, say, for instance, you had an 81-year-old with a history of a TIA or something, just absolute train wreck waiting to happen. But she's like, look, I'm 81. I don't want to live without hormones because I was on hormones before my TIA. And I just feel awful. I can't sleep, and I don't want to live like this.
Gotcha.
And I understand the risk, but I want to do it anyway. How do you feel about that?
So the absolute contraindications for estrogen, any type of breast cancer history, that is a hard stop. We're not going to do that. If you have had a stroke, and this is where it gets kind of tricky. If you've had a stroke, there used to be an app in which you can put in that information. This was the type of stroke. This is how many years it's been since I've had the stroke, in VTE, et cetera. But typically, I still don't put those patients on estrogen because if you've had a stroke, why did you have the stroke? Right? There's usually something else there that has precipitated you being in that situation. And usually one of those issues is going to be a contraindication to you being on estrogen. Because, and although stroke aside, let's say this patient hasn't had a stroke, if I put in all of your other risk factors, you probably are going to show up a little bit higher on that scale anyway. If I were just to calculate, well, what would your primary risk be? You're probably going to fall out of that category of being acceptable to be on estrogen. As far as the 81-year-old who had the TIA, now that's interesting because, again, when did she have it and how long was she on her estrogen before she had her stroke? And so, again, some are just going to say, no, I can't do this for you because you've had a stroke. I'm so sorry. Having hot flashes at 81 is also usually not normal. Yeah. If I were to go back, and I know
It
that.
was mainly fatigue. It wasn't hot flashes.
Okay. I want to get back to this chart. Typically, hot flashes, once you kind of get in early postmenopause and late. So if that's one of the things that they say, because I have patients that are come in and they're in their 70s and they're like, I'm having hot flashes. And I'm like, when was your final menstrual period? When I was 52. Not from you being postmenopausal. It's something else. So it requires teasing. It teases out. The reason why I asked when was she, you have to kind of know when she was on her estrogen is because, again, lowering the dose is acceptable, which is why I stay with that transdermal route, because they have patches that are as low as like 0.03. We might not be doing much from a hot flash standpoint at that time, but some of the other benefits that estrogen have been shown to offer, they may still get some relief on that. I would not start her at 81. I don't start any of my patients over the age of 65 on any type of estrogen therapy. After age 65, sorry, because that's when you're actually going to now increase their risk by starting them on estrogen. They did find that if you start them on estrogen after the age of 65, their risk of cardiovascular disease is going to go up. So that's why I'm a huge proponent of catching them early and catching them while they're in that perimenopausal transition or early menopause transition. Because if you do that, it's fine. But starting them on it when it's late, that's not okay. Provoked versus unprovoked. If it's provoked, and when you say provoked, do you mean like they had a surgery, post-orthopedic surgery? I will have a conversation with their PCP, have a conversation maybe with heme, and kind of talk to them about it. And depending upon how far out they are, if there's someone that's going to need to be on a blood thinner of some sort or one of the other anti-clotting agents, that's when I'm more likely to have that conversation with them. And again, I'll still go with the transdermal estrogen patch because the risk of a clot is lower with a patch compared to being on oral.
So I don't know how much related this is, but I wanted to ask it. And it kind of gets into more like Urogyne stuff, but as far as like patients that are older, that maybe like full-on like systemic estrogen isn't a great idea. Like if you're gonna say 65 is kind of a no-go for starting, and maybe like they need to be kind of tapered at that point, is that when you kind of do you have a conversation with them about doing like vaginal estrogen or anything like that?
Great question. So vaginal estrogen, because it's low dose, that is free game. That is the 81-year-old. So I have 81-year-old patients on low-dose vaginal estrogen. Low-dose vaginal estrogen is fine, regardless of what their risk score is. Low-dose vaginal estrogen is okay. It's the systemic estrogen. So you can keep that patient on their low-dose vaginal estrogen. Yes, no need to stop that. Exactly, and they do not need the progesterone. So low-dose vaginal estrogen does not require progesterone. They can stay on that for as long as they want to.
You mentioned combo patch. Would Xulane also be an option?
So I tend to go, so Xulane, that is the contraceptive patch. I typically will use the Xulane in my patients who are perimenopausal because, again, they need contraception, and that works for them. The thing you have to be mindful about with that is that there is a body weight cutoff, and that number is escaping my brain right now. So if they fit into the category in which they're not contraindicated based upon weight, Xulane is fine.
And in someone who has the elevated ASCVD risk, but is having those perimenopausal vasomotor symptoms, would Veoza be something that you would consider at that point just for regulation of the vasomotor symptoms?
I'm sorry, say which medicine again?
Veoza.
Veoza. So when you say the risk, are you talking about if they fall into that 10% category? Yeah. So pretty much any of the non-hormone based medications to help control hot flashes, that's pretty much where I will go with that. Yep. Gabapentin, Effexor, those different things, Paxil. Yeah. And again, it's how you counsel them and say, I'm not using this to treat you for depression. I'm using this to treat your hot flashes. Yeah. Any other questions? All right. Thank you all very much. I appreciate it.
All right, guys. Dr. Michelle Dilks is a 2004 graduate of the Philadelphia College of Osteopathic Medicine. She completed her family medicine residency at Lehigh Valley Hospital in Allentown, Pennsylvania in 2007. She completed a fellowship in integrative medicine at the University of Arizona in 2017. Dr. Dilks began an independent practice in integrative family medicine in Greenville, Tennessee in 2018. She has served as clinical adjunct faculty for LMU-DCOM Knoxville since 2019. Please help me welcome Dr. Dilks.
Thank you. Okay, so first, before I start talking, I just want to make sure everybody's up to speed on what integrative medicine is, because it's relatively new, and so a lot of you, I'm sure, know what it is, but some of you might not completely know, and I think there's a couple of other fields that might confuse the picture, get other physicians, aware of this and kind of move further into this field. So eventually created a full curriculum called integrative medicine to bring plants, nutrition, lifestyle back into medicine. He always says that, we kind of see it as like the home ec of medicine. It's kind of the simple basic stuff. It's not scientific enough. And that's why we kind of ignore it. We kind of put it to the side as everybody knows what I'm talking about when I say just eat better. And so what he decided to do was to actually build a full curriculum on evidence-based and science-related information to make it less home ec-y and more scientific so that we could bring it back into medicine and try to make it more available and more scientific for our patients. So with that, just so you know, my husband does consult for Johnson & Johnson. You will absolutely not see anything that supports Johnson & Johnson in this lecture. I tend to go kind of anti-prescription, but okay. So when I first was asked to do this presentation, I asked my student, what do you want to see more of? Because in integrative medicine, we do, we cover lifestyle, we cover diet, we cover supplements, herbs, we cover, self-care, meditation. So there's a lot of different things we could talk about that some people might be interested in. She said, I want to see nutrition. I see you do a lot of different things that I don't see in other offices, but the biggest thing is nutrition. That I've been in many offices. She was a fourth year, and she'd never seen any of the doctors she worked with talk about diet and nutrition in the 2 years that she was out there. And she really wanted to see that brought to attention and how much that can affect and impact our patients' lives. So this is mostly about nutrition. And I'll go a little bit into other areas through that, though. So the objectives, I'd like to, again, make nutrition a little bit more scientific for you. So we're going to identify some dietary indices that measure the inflammatory impact of diet. Okay, so we're going to look at some major indices that are used in research studies that help to make a little bit more objective data for how directly does diet and nutrition affect inflammation specifically, and therefore chronic disease. Okay, so the anti-inflammatory diet is the general diet that I tend to focus on and tell my patients to follow more often, and I'm going to give you much more specifics about that. So by the end of this, you should be able to summarize what the anti-inflammatory diet is. And again, anti-inflammatory, talking about how do we decrease inflammation in our body, and that inflammation is kind of a big key topic that's been talked about more and more now, and how it affects chronic disease and the need to decrease general inflammation in our bodies overall. So hopefully you can also use specific components of this anti-inflammatory diet in your future patient care. I'd like you all to be able to step away from this and talk to your patients on a regular basis about specifics of their diet that they need to include in order to decrease inflammation in their body. And then by relating the measurable impact of the dietary patterns on chronic disease, hopefully you can also use those numbers to show your patients how serious this really is and motivate them to move forward with better choices. Okay, so these are the 3 indices that I'm going to concentrate on. There's a lot of different indices that are used in research, but these kind of specifically give, they're very commonly used, and they give just a kind of a chronological order of how researchers have started to look at inflammation and how it's related to diet. So the Healthy Eating Index, the Dietary Inflammatory Index, and the Empirical Diet Inflammatory Index. So first, the Healthy Eating Index. This is just kind of a summary of what it is. It was developed in 2020 off of federal dietary guidelines just to measure overall diet quality. And for this one, you get a total score of 100. So each component has a max score between 5 and 10. And the components are fruits, whole fruits, total vegetables, greens and beans, whole grains, so they're food groups. So for each good food group, you might get 5 points, you might get 8 points. So by looking at an individual's diet and how much, and it's a calculation, so depending on how much of each of those groups and what that score is, more of these good things will get you closer to that 100. There's also some components that are measured by moderating or limiting, so you get positive points for eating less sugar, positive points for eating less refined grains, and that will build you up to that 100. Okay, so the perfect score is 100. The next one is called the Diet Inflammatory Index, and this is a little bit more complicated. It was breaking it down into kind of smaller portions of the diet, more like macronutrients, vitamins, fatty acids. So it took 45 dietary factors that had been found in almost 2,000 studies that modulated systemic inflammatory biomarkers. So they were looking at specific biomarkers and specific parts of the diet that were directly affecting those biomarkers. So markers like interleukins, CRP, TNF-alpha. And this calculation was derived, these 1,943 studies were studies that were from around the world, included many different populations. So it was trying to include all different populations to look at what was the best overall diets to use. So again, the dietary factors included macronutrients, alcohol, fiber, fatty acids, vitamins, minerals, flavonoids, and there was 45 of them, so pretty extensive. So this one, the scoring, it's not a positive to 100 where a perfect score is 100. It's that the more anti-inflammatory or the healthier the diet is more negative, and the more inflammatory is more positive. So a fast food diet is positive, about a +4. The Mediterranean diet is about a -4. The anti-inflammatory diet is about a -8. Okay? Okay. So a lot of research has been done using the DII since it was created in 2009. It's had more than 160 peer-reviewed studies and 12 meta-analyses. With all these studies, pro-inflammatory diets, so those +4 diets, in Europe had been associated with increased all-cause mortality. So the European studies were able to show all-cause mortality was increased by eating more inflammatory diets. The US studies were a little bit different. They were basically able to show increased depression and metabolic syndrome. So the researchers who created the DII looked at this and they said, how do we get such a difference between Europe and the US, where Europe can show all-cause mortality and the US can only show depression and metabolic syndrome? What's going on? And when they looked at it, they felt that the studies in the US were being misused. The calculations were being misused because it was too complex. So they decided to make a second indice that was just a little bit less complex, that couldn't be adulterated quite as easily. So that's how they came up with the Empirical Dietary Inflammatory Index. And this was mostly to concentrate on the US population. So it wasn't the worldwide population that the DII had. It was focusing just more on the US population and came from data from the Nurses' Health Studies 1 and 2 and the Health Professionals Follow-Up Study, which I think we all know are pretty big studies that gave a lot of data. So a little bit less complex and not transferable across worldwide dietary intake, but hopefully less more easy to follow and less adulterated in studies, which unfortunately can be a problem in research. I think anybody who's studied statistics knows that numbers can be moved and skewed to the way that you want it to, and anybody who's done research knows that if you want a certain outcome to happen, you can make it happen almost any way that you want, unfortunately. Okay, anyway, EDII components, they're similar to the healthy eating index, so kind of going a little bit back to the healthy eating index, but with a mix of the DII. So it was a little bit more just food groups rather than those 45 breakdowns of diet, it was food groups. So there was 8 pro-inflammatory food groups and 8 anti-inflammatory food groups, okay? So the pro-inflammatory red meats, processed meats, organ meats, certain fishes, like the larger fishes containing mercury, eggs, sugar-sweetened beverages, tomatoes, and refined grains. And then the anti-inflammatory foods, lots of veggies, fruit juice, oily fish, coffee, tea, and moderate wine and beer. Okay, so looking at these 3 indices, like I said, there's a lot of different indices that have been used in research. I just focused on these 3 because they're commonly used and they gear more towards inflammation. And inflammation and chronic disease is where I tend to focus the most. How can we keep you from getting chronic disease? How can we keep you from getting diabetes? Or if you have diabetes, how can we turn that around? So most current research indices focus on inflammation and how can we decrease that inflammation. In general, it's important to focus on overall composition of the diet, okay? So the food groups and how much you're taking of each different group, not just telling someone eat less sugar and everything will be fine. You also need to add what do they need to include in their diet, how much of a balance of a diet, and different specific pieces of everything that they're putting in their diet that will help to keep them and prevent them from getting that cardiovascular disease, the diabetes that goes along with it as they age. So this is one of my favorite quotes, and it's a very simple short phrase. I'm sure a lot of you have seen this before. It's a popular quote, but it says, the first time I saw it, I was just flabbergasted because it says so much in such a short amount of words. The first 2 words especially, if you want to explain to your patients and you don't have any time, just tell them this phrase right here, because it will give them just kind of an overall comprehensive view of how you want them to eat. So eat food. What does that mean? That means eat real food. 85 to 90% of what's in the grocery store is not real food, okay? So real food means, did it come out of the ground? Did it come straight from an animal and was not adulterated by hormones and, is actually eating grass and is out in the field? So eat real food. It encompasses a lot of different details, and we could go into a lot of those details, but if you can just take that in your mind, is this real food or was it made in a factory? That's the first thing that you need to look at as your base. Not too much. So I'm not about restricting specific calories. I'm not about going on some fad diet, but make sure that you portion control, okay? Eat real food and don't constantly eat and constantly binge. Make sure that you're keeping yourself in regular balance. And then finally, mostly plants. I don't typically ever recommend a vegetarian or vegan diet. There may be some in this audience, and I tend to get some backlash from people who are strongly vegan. I don't tend to recommend that. I think we are based as omnivores, and I think there's plenty of things that we need that come from animal products. So I do think that we need them, but way less than most of us eat. Most of us eat meat 3 times a day, not 2 to 3 times a week. Okay, so again, this is the diet that I tend to recommend mostly to my patients. And basically, again, it's not a fad diet, it's not calorie restriction, it's a way of selecting and preparing anti-inflammatory foods. So what foods are you picking? How are you cooking them? How are you making them? How are you preparing them? When are you eating? How are you eating them? And it's based on scientific knowledge of how they can help your body maintain optimum health. So everything that's in this diet has evidence to support that it will decrease inflammation in your body. It will prevent chronic disease. It's based in general on both the Mediterranean and Asian style diets. So a lot of the things in this diet, a lot of us may not be used to eating. It's definitely not the standard American diet. So this, and you may not be able to read all the words, and that's fine, but this is just kind of a picture pyramid to get an idea of what the anti-inflammatory diet looks like. I don't know if any of you remember when I was in kindergarten, we had the little felt board, and you go up and do the FDA pyramid, and you put the piece of bread up and the milk up. And the base of the pyramid when I was a kid was milk and bread and meat and dairy, and then vegetables were kind of up at the top. And so we've basically flipped that pyramid upside down. Fruits and vegetables need to be our main base. Okay, again, I'm not vegetarian and I don't encourage it, but it really needs to be a lot more than most of us eat. You want to get at least 4 to 5 vegetables a day and 3 to 4 fruits a day. And that means whole food. Again, eat food. Whole fruits, whole vegetables. Not canned fruit, not fruit juice, not canned vegetables. And I think if a lot of you ask your patients, especially in East Tennessee, what vegetables do you eat? And they're going to say green beans and corn, and that's pretty much their limit. So if all you do is encourage them to expand that to a few different other types of vegetables, I think that would be really helpful for a lot of people. Okay, so if you go to drwild.com, you can pull this pyramid up. I print this out for almost all my patients and tell them to put it up on their fridge. It's just a really good kind of image for them to see so that every day they can be reminded of what different things are they supposed to be incorporating in their diet. So diet it's very complex, especially something like this. It seems like something simple, but it is pretty complex to make sure every single day you're getting all of the different things that you're supposed to be getting into your body. Okay, so seeing it every day can remind you when you're making dinner, oh, okay, well, maybe I should, make this tonight or add this tomorrow, okay? So have them have it in their face every single day so that they can continue to take that knowledge in. You can also, on that website, has a lot more specifics. We're gonna break down this whole pyramid. We're gonna look at specifics of what each different piece means and how to incorporate it into your patients' lives. Okay, so these are the components. Starting with the top of the pyramid, or the least important in my view, and then going all the way down to the bottom, okay? So healthy sweets and red wine, you don't have to include these. They do have some antioxidant components, but most of us are already eating junk, so this is more to tailor people to how to eat better options and less of it. If you're not eating any dessert and you're not drinking wine or alcohol, you don't need to add that to your diet. But if you are already, these are some options to transition to a little bit better options. Supplements. You don't often see things like supplements and tea in a diet. What that is for is to help bridge the gap, because no matter how perfect we are with our diet, none of us are going to be 100% and get everything that we really need. So adding some of the base supplements, especially things that that maybe you don't get as much of, can be important. Tea has medicinal components to it and can be really helpful for decreasing inflammation. Healthy herbs and spices as well. A lot of us don't know how to cook with herbs and spices, and just adding, I tell my patients just to add one different spice or herb a week to their food. It takes a long time to learn how to cook, and most of us don't cook at home anymore, and it's getting worse and worse, unfortunately. We were driving up to Philly last weekend and we had to stop to get something to eat, and there was a strip mall, and 75% of that strip mall was restaurants. Something that we never saw 20 years ago. It was all stores, and now the stores are going out of business because they're all online, and it's all restaurants. We're all eating out all the time. We need to start getting back to cooking for ourselves. So again, just once a week, try out one recipe a week, try out a new herb that you never heard of once a week, and see if you can start expanding on your palate just a little bit at a time. Protein sources. Cooked Asian mushrooms, a lot of people might not include mushrooms in their food. but they do have a lot of medicinal properties. Whole soy foods, we'll get into this. A lot of people cringe when I say the word soy, but we'll get into that a little bit. Fish and shellfish, healthy fats, whole and cracked grains, and we're going to discuss specifically what that means. Pasta, cooked al dente, again, not mush. Anything mush is going to be digested more quickly and therefore have a higher glycemic load, higher glycemic index. So the less mush that you eat in your diet, the better for your blood sugar. Beans and legumes, and then again, vegetables, fruit, and water. Water, not like the, I think the last lecturer said something about a caramel frappuccino or something. Too many of us don't know how to drink water. Okay, so we're gonna start just breaking down each piece. So what are healthy sweets? Again, sparingly. If you don't eat dessert right now, don't add it, but most of us already do. So see if we can start cutting back. And the options should be more like an unsweetened dried fruit, a dark chocolate, or like a fruit sorbet, okay? Not the cakes and cookies and candies. Dark chocolate has some polyphenols with antioxidant activity. So again, anti-inflammatory. And when we talk dark chocolate, we're talking 70% or more of the cacao, which has that antioxidant capacity with it. And limiting to just a few ounces a week, so not a Snickers bar every night, okay? Just a couple ounces. And it's getting more and more common. You see them, in the candy aisle. You can get them already made kind of in the half ounce or 1 ounce squares so that people can kind of measure it out for themselves. Okay, and red wine, again, if you don't drink it already, don't start, but try to limit to 1 to 2 glasses a day. I think all of us have seen the data. For men, it's supposed to be 2 a day, for women, 1 a day. I'm a little bit of a taller woman, so I associate myself with a man, but I try to keep it to 1. And again, it matters what kind that you're drinking. So grapes, I don't know if any of you have tried to grow grapes, especially in East Tennessee with the fungus that we get. It's one of the hardest plants to grow. So when you're getting wine, most of it has been adulterated with pesticides and all kinds of different sprays. So try to get organic if you possibly can, because it does make a big difference. Again, red wine does have very beneficial antioxidant activity. I think a lot of you have seen data on the resveratrol and cardiovascular health. But again, if you don't drink, don't start. This is more for encouraging your patients to cut down. I don't know if a lot of you saw in COVID the kind of uptick of alcohol use. I think we've come down a little bit, but it's just been an immense raise in alcohol use that a lot of people are really not talking about. It's still kind of, hush hush, and they keep it in their home. So make sure you ask, how much are you drinking, and what have you gotten used to as the norm? Okay, so again, supplements, and this is different for every patient. Again, we try to practice patient-centered medicine. A lot of people will ask me, well, what supplements do you recommend? And I say, I can't give a general recommendation to anybody. I have to see the patient, I have to decide what are they missing and what do this specific person need. But in general, kind of the main things might be CoQ10, fish oil, vitamin D, and a high-quality multi-mineral multivitamin. I usually recommend a whole food multivitamin. There's a lot of different brands out there, and they're becoming more popular, but they're much more bioavailable than something like a synthetic Centrum. All of the kind of the Centrums and those type of vitamins, they take synthetic, individual pieces, and then they kind of mush it together into a vitamin. When you're talking about a whole food multivitamin, it's basically just taking fruits and vegetables, dehydrating them, and sticking them in a capsule, okay? So you're getting the fruits and vegetables that you might not be eating enough of, and that will give you a much broader array of fully whole food, bioavailable multivitamin and mineral that you need, okay? And again, this is really just to fill the gap. If you are perfect with this diet, there's no gaps that you're gonna need to fill. Okay, so next, tea. A lot of us don't drink tea. We're not English. but it is a really good habit to get into. And also, again, on the alcohol part, if you can kind of encourage someone to maybe have a cup of tea after dinner instead of that second or third glass of wine or whiskey or whatever it is, it might help to calm you down before bed, but also is medicinal and anti-inflammatory for you. There's a lot of great teas, and cheap. Two of the best teas for digestion, peppermint and ginger. Peppermint has really great evidence and data to help with inflammatory bowel disease or irritable bowel disease. Helps to kind of calm the back and forth diarrhea, constipation, because it's an antispasmodic. So anybody who has a cup of peppermint tea with a meal, if they have irritable bowel syndrome, can really, without medications and other, interventions, can really help to calm that irritable bowel syndrome. So just that simple intervention. So tea is rich in catechins, especially the ones that listed, white, green, oolong, herbal teas. The black teas, which are kind of the most common, like Lipton, they're okay, but they do have a lot of tannins. They can dehydrate people, make you a little bit kind of dried out. So not quite as good and not as much of the medicinal benefit, especially if you steep it too long. So again, purchase high quality tea if you can and make sure you brew it correctly. So if you just kind of leave that tea bag in there and let it sit as you're drinking it, sometimes too much, like especially with the black tea, the tannins will come out. You'll start to notice your mouth gets real dry and it's not really as beneficial for you. Okay, so healthy herbs and spices. Throw on as many as you want. We're not talking about salt and sodium, but herbs and spices like turmeric, curry, ginger, garlic, chili peppers, basil, cinnamon, rosemary, thyme. These are all medicines, really. Turmeric, hugely beneficial for arthritis. People are taking it as an extra supplement. Just throw it on your food. Just make that food that yellow-orange color. And it's not gonna make it spicy, it's just gonna make it more flavorful. Ginger is really great for digestive health and anti-inflammatory. Turmeric also has some really great evidence for cancer prevention. Chili peppers, good for blood sugar maintenance, as well as cinnamon. Cinnamon is actually being used by a lot of diabetics to help control their blood sugar. Okay, so protein sources. Again, we tend to eat, this is kind of the base of our diet is protein sources. So I don't tell people to take it out, but much less than we are. Instead of 2 to 3 a day, try to, for these protein sources, try to do 1 to 2 servings per week. So protein sources would be natural cheese, yogurt, pasture-raised eggs. There's a huge difference between pasture-raised eggs and factory eggs, which I think most of us have seen, just the color change in the omega-3 quality. Skinless poultry, grass-finished lean meats. The omega-3 content of a grass-finished beef is basically the same as a pasture-raised chicken, and also very similar to wild-caught fish. So a lot of, especially vegetarians and vegans, will kind of throw that data that that's the best diet, and it's not good to eat beef because it's so inflammatory. Most of the studies have been done with factory beef, factory chicken. If you look at grass-finished lean meats, pasture-raised chicken, the omega-3 content and the inflammatory components are mostly equal, okay? But in general, try to reduce the consumption of animal foods, okay? We don't need that much, but good options and few. So cooked Asian mushrooms, and I say Asian mushrooms specifically, like shiitake, maitake, oyster, and wild mushrooms. They contain compounds that enhance immune function, okay? You never want to eat mushrooms raw. So anytime you have mushrooms, just lightly saute them. And the reason is because a lot of mushrooms have some toxins in them, and they are released when you lightly saute them or cook them. But you kind of can build them in your system if you eat them raw. Especially the commercial button mushrooms, those white mushrooms are a little bit higher in the toxins. So it's very common to see salads with the white mushrooms all over that are raw. I would definitely avoid those if you can, because they do have a little bit of toxin in them. So the most common and the cheapest ones, unfortunately, the cremini and the portobello ones that you see in the grocery store are not quite as medicinal. You want to try to get the Asian mushrooms, and again, just lightly saute. You don't want to overcook anything, just lightly saute. Okay, so whole soy food. So how many of you have heard that soy is not good for you and that you should avoid it? Okay, I just see one, but I see some nods here and there. That's the cringe that I get from a lot of my patients. So there had been some small studies in the past, and they were marketed very well, to show that soy increases the risk of breast cancer. So we all kind of stopped soy altogether. Those few studies basically used soy isolate and soy protein powder as a supplement. And they were kind of equivocal whether they did or didn't push, breast cancer. When you look at all of the research over the last 20 years or more, with meta-analysis, reviews, large studies, looking specifically at whole soy foods, not only do they not cause breast cancer, they help to prevent most cancers and are very anti-inflammatory. So again, eat food, whole soy foods, and also organic as much as possible, because soy is used in a lot of different products, and so therefore a lot of GMO is out there. But you can get organic whole soy foods, and they are very anti-inflammatory, have compounds such as isoflavones. They're actually also phytoestrogens. So as our last presenter was speaking about perimenopause, which unfortunately I am currently going through, and it's not fun. Soy is a really great, just kind of simple, again, whole food that you can offer to your patients that can help to just boost that estrogen before you get to the point of hormone replacement. So have them have a glass of soy milk before bed. It's amazing how calming and relaxing it is. Or if they wake up with the hot flashes, a glass of organic soy milk, just to kind of boost that estrogen and calm that agitation. So other options, again, probably foods that most of us have not really experienced and might look a little bit weird, but the more you talk about this with patients, the more they might try. So edamame is kind of a common thing that I can get my patients to delve into. Just say, throw it on a salad. It's like little nuts. Throw it on a salad, or take a bag with you at work and just kind of snack during the day. Soy nuts, soy milk, and again, all of it organic if you can get it. Again, choose the whole soy foods over fractionated foods. A lot of the processed foods have those soy protein powders in the imitation meats, and they're made with soy isolate, and those are not good. Those are very inflammatory. So fish and shellfish, these are kind of the better fish in general, for mercury especially. If you're looking at the small fish like sardines, they have less exposure to the mercury because they don't quite live as long and they don't kind of collect quite as much of it. And sardines have a very high omega-3 content. So if someone's looking for a quick, easy snack to bring to work or a lunch, if they like it, just tell them to get a can of sardines and either stick it on a salad or a wrap or something like that, and just kind of snack on that. But there's also other fish, Alaskan salmon, herring, black cod. I know fish is getting more and more expensive because especially you want to try to get the wild caught as much as possible, because the farm raised, again, anything farm raised, factory raised, you're going to increase that omega-6 and that inflammation versus the omega-3. So anytime you're eating any food, eat real food, not factory processed, and not fed corn. So healthy fats, you want 5 to 7 servings per day, and this is, a serving is about a teaspoon of oil, 2 walnuts, flaxseed, 1 ounce of avocado. Those are different forms of healthy fats that you can eat. For cooking, try to use extra virgin olive oil and expeller pressed grapeseed oil, and the reason is just the way that the oils break down, and those are very high in omega-3s. Nuts, avocados, seeds, sunflower, safflower oil, walnut, hazelnut oils, and dark roasted sesame oil are some other good options. So again, rich in either monounsaturated or the omega-3 fats, less of the double carbon bonds. Whole and cracked grains, this doesn't mean bread. It doesn't mean whole grain bread at all. It means whole grains. Anything that's actually you can see as a whole grain. Brown rice, basmati rice, wild rice, buckwheat groats, barley, quinoa, steel-cut oats. Okay, the bread, again, anything that's pulverized or mushed is not good for our digestion and not good for our blood sugar spikes. So any kind of flour, I know the gluten-free craze has been going on for a little while where, well, if I eat the rice flour or the almond flour, that's less inflammatory, that's better for me. It's still pulverized, it's still flour, okay? So we're still getting that glycemic spike. So try to avoid the flours of all forms as much as possible. And again, eat food, go back to the whole food, the real food, okay? So any kind of bread, even if it's the ancient grains. Everybody's always trying to come up with an well, can I eat the ancient grain bread? And can I eat the whole grain bread? Bread in general, not good. If you can't get rid of it, try to go for a little bit more of the chunky kind of whole grain bread or sourdough, but really it should be kind of out of our diet. Again, the whole grains digest slower. They reduce the frequency of spikes in blood sugar that promote inflammation. So again, pasta al dente, meaning undercook it just a little bit. And this comes back to, again, any kind of mush is going to digest a little faster and spike our sugar faster. So you want to try to get organic pasta and cook it a little bit under. And then there's other options like rice noodles, Japanese udon, beans and legumes. That might be something else that we don't include in our diet quite as much. This can help to kind of fill that carb gap if we're getting rid of the breads, we're getting rid of the potatoes and the other types of processed foods. Throw some beans on your plate and it'll help fill you up and give you some of those carbs, but they're a little bit slower processing and have a lower glycemic load. So chickpeas, you can make some hummus. That's a quick, easy snack to bring to work. So eat them well cooked, either whole or pureed. And again, spreads like hummus you can use. Okay, so vegetables, we're getting to the base of the pyramid. 4 to 5 servings a day, minimum. That's difficult to get, but a serving is usually about a half a cup or so. Okay, so you can have a dinner plate with a big thing of broccoli, cup and a half, and that's 3 servings right there. So you don't have to think about, oh my God, how am I going to eat 5 times a day? You can just eat larger portions or try to mix things up to do 2 servings of different vegetables. And when we're talking about vegetables, we're talking about trying to get the rainbow, trying to get as many different kinds as possible, not just mushy green beans cooked in bacon and corn, okay? So spinach, collard greens, kale, Swiss chard, all that stuff grows really well well, spinach doesn't do really well here, but the collard greens, kale, Swiss chard does amazing here. It'll last till Christmas in your garden and you have to do almost nothing to it. Just go out and clip some and you've got some really great vegetables. The cruciferous vegetables, they have a ton of evidence, especially broccoli, a ton of evidence for cancer prevention. Broccoli, cabbage, Brussels sprouts, kale, bok choy, cauliflower. Bok choy is a great vegetable to cook with. I'd encourage more of you to use it. Every time I buy it at the grocery store, the girl is like, what's this? What's this? Nobody buys this. Carrots, beets, onions, peas, squash, and raw salad greens are other options. So again, their vegetables are rich in flavonoids and carotenoids, both antioxidant and anti-inflammatory activity. Fruits, you want to get 3 to 4 a day. We're not talking about canned fruits. We're not talking about juice. We're talking about whole fruits. and try to get the lower glycemic load fruits if possible, the berries. Peaches and oranges, grapefruit are okay. Red grapes rather than the white, plums and pomegranates. So try to avoid the tropical fruits if you can. They're much higher glycemic index. And water. This seems pretty simple, but is probably one of the most difficult things for me to get patients to do is to drink water. They don't like the taste of it. And every time, that's my biggest eye roll, my internal eye roll, when somebody says they don't like the taste of water. There shouldn't be a taste to it. and don't offer them alternatives. The packets with, with the sweetener, or can I add this, can I add that? No, just plain, straight up, high quality H2O, like the water boy would say, just water. You can have some tea, add the herbs of the tea to it. If you really need fruit juice, a very dilute fruit juice, and try to make it from natural fruit. If you think about like a cup of orange juice, how many oranges does that take to make just a cup of orange juice? If you actually squeeze that yourself, it's probably 20, 25 oranges. So you're squeezing all of that sugar out and avoiding all the fiber when you're not just eating the plain orange. Okay, so fruit juice is extremely high glycemic index. We want to try to avoid that at all costs. If they need an option, just tell them cut a slice of lemon and squeeze the lemon in the water. That'll give them a little bit of flavor. Okay. So clinical correlation is important so that we can encourage our patients to eat like this, because this is a lot of different things that you're going to try to push for your patients. And how do I have the time to do this? Even if you just show them the pyramid and you just talk a little bit about it, you need to tell them how important this is and how much of a difference it will make in their life. So it's estimated that unhealthy eating poses a greater risk to illness and mortality than illicit substance abuse, alcohol, and tobacco use, along with STDs combined. It's the most important problem that we're dealing with. So we're going to start with some data with childhood obesity. Everybody knows that that's increasing. It's estimated, and this was 7 years ago too, actually, but so these kids are already starting to get a little older. 3 in 5, by the time they turn 35, will be obese. I think we're already getting towards that. There was a large prospective study that showed children over a 7-year period, if they could just follow the Mediterranean diet, that it would inversely associate with their BMI. So just getting them to eat a little bit better will bring their BMI down. And again, it's not about calories. I know, especially with kids, we don't want to shame them. We don't want to put them on a diet, but you want to teach them how to eat well and what types of foods to eat. So a recent meta-analysis of 15 cohort studies showed that diets with the highest DII score, so that fast food pro-inflammatory diet, was associated with a higher cardiovascular disease risk. I think that's kind of common sense. All of us know that. You eat fast food, you've got a higher risk of cardiovascular disease. Also showed that those with the highest, most pro-inflammatory diet versus those with the lowest anti-inflammatory had a 2-fold increase in the risk of developing cardiovascular disease, 2-fold. I don't think statins have that data, okay? So show them that. Show them that by changing their diet, by continuing what they're doing, they are doubling their risk. And if they just change their diet, they can half that. A statin is not gonna get them that, okay? I'm not saying don't use statins and that they don't give some benefit, but don't use it instead. Make sure that that's first line. It's supposed to be in all of our societies, diet is first line in everything, and we tend to skip that over. We tend to see that as non-scientific and simple and stupid, and everybody knows, just eat better. And our patients don't get that communication when we skip that over. Because in our mind, we know, well, they should eat better. Well, they're not gonna listen to me, and what does it matter if I tell them? They're not gonna change, so I'm just gonna give them the statin. Every single visit, we need to remind them that this is number one, diet's the number one, and this is gonna reduce your risk by half if you do this. The statin's gonna give you a little bit, but it's a Band-Aid. It's not gonna fix the problem. So let's keep reminding our patients of what the most important part is, and every single time we see them. Diabetes prevention, a study over 20 years of data from the Women's Health Study showed that higher adherence to the Mediterranean diet was associated with a 30% relative risk in reduction of type 2 diabetes. So decreasing that risk by a third. Cancer prevention, a lot of patients, I think we've seen all this data, but patients might not know that cancer can be prevented by eating an anti-inflammatory diet. And even after you have cancer. So this data is important, I think, to show to our patients that maybe already have cancer, that the highest DII index had a 25% risk of overall cancer, but also 67% increased risk of cancer mortality. After you have cancer, if you're still eating that pro-inflammatory diet, you have 2/3 higher risk of dying from that cancer. I get a lot of cancer patients, unfortunately a lot of them too late, that say, what can I do to, naturally treat this cancer? And, I tell them, that ship sailed. You're on the Titanic. You're going down, But can you decrease your risk? Yes. If we get this inflammation down in your body, maybe we can increase the risk that you're going to have more complications or die from this cancer. But definitely it's something you should be doing beforehand, but we can also do at any point in time, which is important to know. This is huge. I think we're all seeing a lot, more and more dementia. A lot of people call it type 3 diabetes. In 1,000 non-demented individuals, over the age of 64, they were followed for just 3 years. So if you talk to all of your 64-year-olds and say, if you follow a Mediterranean diet for the next 3 years, you're going to reduce your risk of dementia by 72%. How many of them do you think would follow that Mediterranean diet? Especially the boomers. I think this class of going into their 60s and 70s are really interested in staying active and healthy as long as possible. So I think you'll get a lot of bang for your buck if you can give them this data. Listen, you don't have dementia now, but you just saw your dad die of it last year, and it was really bad, right? Do you want to go through that? No. So this is what you can do to reduce your risk by that much. This was just a really neat study that I saw that can encourage your patients that even just a short-term change can make a huge difference. So when you have that 35-year-old woman and you give her a prescription for Paxil for her depression, try to also tell her, listen, we've seen that even just in 10 days, if you can switch to an anti-inflammatory diet, your mood will significantly improve. So take that Paxil, but also eat better, and you're going to feel overall better, and you're going to improve your mood and improve this depression. Rheumatoid arthritis, yes, we do have some great medications like TNF inhibitors. They do have a lot of side effects and concerns, long-term concerns. So if you can decrease those markers with an anti-inflammatory diet, how much better is that than getting to the point of the TNF inhibitors, even if you just add it on top of it. This was impressive data to me, the asthma, that a DII score for every unit, asthma increased by 70%, just 1 unit. And 1 unit also in the DII decreased your FEV1 by 3.44%. So as you're giving them the inhaler, just let them know, if you can just make a small change in your diet, you can reduce your asthma risk by a huge percentage. Healthy aging. So for people like me, the middle-aged, if I switched right now to a stricter anti-inflammatory diet, I could improve my risk of healthy aging, meaning less chronic disease, like the woman was talking about last about her 91-year-old grandmother, not on any medications. That's what I want to be. That I have a 36 to 46% greater likelihood of healthy aging if I do that now. If I'm elderly, 65 plus, look at the bang for my buck that I get. I can wait till I'm 65, and I get almost 300% better successful aging if I can follow an anti-inflammatory diet, okay? So a lot of people kind of give up by that time. They say, well, I've already got CVD, I've already got diabetes, what's the point right now? Well, that's the point, that you can increase or decrease your risk of chronic disease by that much. Okay. So in summary, the evidence supports that anti-inflammatory diet instruction should be first-line therapy for every single patient. Every single time they come in, even if it's just one phrase, don't throw it away. Don't just say eat better. Use this data and give them specifics. What do they need to add in their diet? What are those dietary things going to do for their chronic disease? How are we going to decrease inflammation? Give them that scientific clinical correlation that we give with our prescriptions. When we give a statin, we give all the information about why they need to be on the statin, why do they need to be on the blood pressure medicine. Do the same with the diet and make sure that that's first-line therapy and not last-line therapy, okay? So again, discuss dietary habits at every visit, and the review and discussion of adherence should be considered just as important as medications. Okay, any questions, anybody? Yep.
I have a few pages. I'm sorry, I'm just, okay. Okay, first one, I guess, was red wine and only organic. So does that mean there is no benefit to white? Is it harmful?
No, it's not harmful, but red has the resveratrol, which has been shown to have a little bit more antioxidant and cardiovascular protection. So white wine is okay, but if you're looking for that antioxidant component and the resveratrol, again, every component in here has data behind it that pushes it forward. So I wouldn't say that white wine has bad data. And again, beer, I mean, I think beer with the hops has a lot of, potential good data as well. The carbs in it might be a little bit off-putting too, so I think you just have to look at the balance of all of that.
With spices, herbs and spices, you said, like, I guess, thinking of salt as an unhealthy one.
Well, I wouldn't say salt, but when I said load it on and don't worry about the amount, you want to worry about sodium.
Are there other examples of things you can't load on?
No, as far if it's an herb or a spice and it's a real food, no.
Okay.
Unless it's, chili peppers and it burns to the, I mean, my husband makes his own hot sauce and it literally one drop will do you. So yes, if it's too much and it's going to burn your throat, no, but as much as you can tolerate.
And a part of this is because my family is going through doing this right now, and because of my wife, and so it's hard.
Yeah. Oh, yeah. And again, that's why I say, put the thing up on your fridge because it's an everyday thing. I mean, I've been studying this for many years, and I still learn something new every day. So just bringing it into our forefront as this is scientific and this is important, and most of us don't know anything about a lot of this. And we, even in medicine, as doctors, we need to learn. We didn't learn any of this stuff in medicine at all. It's like we just kind of pushed it to the side like it's not important.
Nuts.
Yeah.
So all my kids will eat is peanuts and cashews, and I think that those are the worst.
Yes.
Right?
Yeah.
Are they still good, or are they just worthless?
I mean, the peanuts especially are a little bit inflammatory, so everything in moderation. Nuts are better than chips, so peanuts and cashews, I would say, are better than chips, but you probably want to get the unsalted and the dry roasted rather than, because a lot of the peanuts are roasted in, lots of artificial oils and things, so.
And then I'll leave it alone, but I'll try to finish up with, one was...
I think we're okay with time anyway, right?
So tortillas, as far as culture, Hispanic culture, I try to tell them don't eat tortillas, and they look at me like I'm insane. And then the last thing is the cost and kind of food deserts.
Yeah.
My family is having a hard time affording this diet, and we have a lot more money than a lot of people.
Yeah. It is, well, it is, one thing I would say is the cost of medicines and chronic disease far outweigh the cost of food. But secondarily, there are plenty of options. It just takes time and research. So even like in my small town, I live in Greenville, which is kind of a very rural town. I wouldn't call it a food desert, but, because we have a lot of farms too. But, there's options like Aldi has really great produce and vegetables that are way cheap, half the price of the normal grocery store. So look in your town for less expensive options that you can offer to your patients. And try to seek them out and try to figure out for yourself. Again, I'm glad that you're doing this for yourself and your family, because I think you have to do that for yourself. You need to follow the diet yourself so that you know the ins and outs. And when your patient comes to you and says, I can't afford fruits and vegetables, you know, if you've looked into it and you've looked to see where you can get better options, I think that's helpful. And again, if they can't, even if they go forward towards that, even if it's just the taking out of the stuff and drinking water instead of Mountain Dew, every step is a step in the right direction, right? Yeah, yeah. There's a lot. I mean, we have farmers markets and farm shares, which those can get expensive too, definitely. But just kind of looking around to see where your options are. And you might have to go back to the way we used to do it, where you shop for different things in different places, or grow your own. You know, there's a lot of things we can grow here in East Tennessee. My garden goes through Christmas, and it provides us with most of our fruits and vegetables. And I have a 40 by 20. It's not really huge, and it doesn't take a ton of work. We have plenty of rain that we don't need to keep up on it.
When you were talking about like no canned fruits and stuff.
Yeah.
Legumes, when you're talking about like legumes and beans and everything, canned options, is like
It's
buying-
cheaper, yeah. I would try to avoid it, but
sometimes.
if you're going to do cans, try to do BPA-free and, you know, no sodium added, and really look at the options that you have. Because the problem with cans is, first of all, they're kind of mush. So like I said, anything mush is going to digest faster and give you that higher glycemic load. But also they add a lot of stuff to it. So go back to the eat food. When you look at your box of food or your can of food, do you know what all these words are? And that's the one thing I tell my patients. If you don't know what that is, that dihydroxycarbo, whatever it was, don't eat it. Because if there's something in there that is a chemical and you don't know what it is, then put it aside and try to find a better option. And again, I know it takes a lot of work. It takes a lot of work. It takes a lot of change to not, and meet your patient where they're at. I mean, if they're eating McDonald's every day, start with that. Listen, we can't eat McDonald's every day. Make one meal a day or one meal a week and try to look at options that they can do. Try to, you know, maybe grab the bags of salad if you have no time and just kind of throw that with some sardines as your lunch instead of going out to lunch with everybody at work and things like that. I think it's individual to every patient and every person.
That brings us to 10 o'clock. If
What-
you want, we can go ahead and take a quick break till 10:15. You're welcome to ask your question, but you're going to be around for just a minute too if they've got some
Yeah.
others, right?
So I was just curious when you were talking about the soy products. So I purposely avoid soy because, like you were talking about, it has higher estrogen content, and like for women to use it at night as a way to maybe avoid estrogen supplementation. And like, does your recommendation change at all for like kind of males of any age as far as soy?
No, and that's actually been studied too. I'm glad you brought that up because I forgot I was going to say that. That's been looked at in prostate cancer and, you know, androgenism, and it does not affect males. It does not, you know, give them more feminine qualities. It does not increase their estrogen. It does not increase prostate cancer risk. So there's been a lot of different things that they've looked at for males, and it is still beneficial. I would still encourage, again, the whole soy foods, not the soy isolate and the proteins, but whole soy foods for men as well. Because, you know, in men, we take that phytoestrogen, or they take that phytoestrogen, and it basically binds to the estrogen receptors that you already have. It's not going to increase your use of estrogen. It's just going to help to balance your hormones out and your testosterone. And again, your body itself is going to kind of balance in that DHEA pathway, and very anti-glycemic and anti-inflammatory. So I would recommend for you as well that you could include it.
I know you said fresh fruits and vegetables if possible, but if you're not able to get to the grocery store every few days to get that, or you don't grow it, what is your opinion
Frozen.
of frozen versus dehydrated versus freeze-dried? Which is best?
Frozen definitely would be next. Dehydrated, as long as you're not adding things to it or you're doing it yourself, because a lot of dehydrated fruits and vegetables, they add a lot of sugars and things, like if you buy it in the grocery store. So if you can find a good brand that doesn't add a lot of junk to it, then you can do the dehydrated. But frozen typically is just kind of, so especially for the fruits, you know, in the winter, get those frozen bags of berries and things that they have, make a smoothie out of them. It's just the fruit, and you're not losing any of the quality, and can be really a lot cheaper and easier to use. And smoothie, everybody loves doing smoothies because you can mix a lot of stuff in there and just kind of get it on the go. Although, again, anytime you break stuff up, you're not getting quite as much of the nutrition, but it's a lot better than not getting it in there at all.
Have you found any shortcuts for, I mean, we talk about the food deserts, we talk about cost, but we don't really talk about the factor of convenience. And I'm just going to be vulnerable and say I'm a single mom and I'm busy and I have a toddler and she doesn't like for me to spend forever cooking, and then she eats like a bird and wastes it anyway.
Yeah.
So it's like, why slave away cooking a meal when she's going to eat 3 bites of it and be done?
Yeah.
So have you found any shortcuts to where, and like when we're at a conference like this and we don't have a kitchen, we're not able to cook, if you have to eat out, have you found any meal kits or, you know, anything that makes the convenience factor easier?
Yeah,
to eat
and I think
healthy?
it's definitely different for everybody. Some people like the meal kits. I use something called e-meals, and I've used it for years to try to get my kids to eat better at home. It's cheaper because it's just a simple, cheap app, and it meal plans. So I think the biggest, most important thing for families is to meal plan. And meal planning on your own is a huge amount of work, to sit there and find 5 recipes for the week and then find every ingredient and then go shopping every week. But apps like e-meals, they do the meal planning for you. You just pick whichever meal you want. And I usually do like 4, and then we do leftovers for other nights. And they tend to take maybe 20, 30 minutes to put together for a full family. So if you think about the time that it takes to drive out and pick up food and wait in line and then bring it home, that's probably about 20 to 30 minutes. So if you can maybe do your food shopping once a week, you can fill with full fresh fruits and vegetables. If you can only do it every couple weeks or, you know, once a month, you might have to do more of the frozen and things like that. But meal planning is really the best way, so that when you get home and you're tired and it's late, it's already there. All you have to do is follow that recipe. And you're not spending that extra money on the meal kit. The meal kits can get expensive. If somebody's got plenty of money, and I have plenty of the boomers especially that, you know, have extra money and extra time, and they'll do the meal kits, or they'll just do it on their own. But most of us don't. So the apps can be really helpful. Or just, if you are out, just try to be a little bit more sensible. And in a place like this, there's really almost no options. But you just have to, when you are out and when you have no other options, just try to limit as much as possible.
Thank you.
All right, thank you.
I'll go ahead and get us started, okay? All right, guys, we're going to go ahead and get started. I know I said 10:15, but thankfully, Dr. Todd has been able to make it, and we're very grateful for that. William Andrew Todd, DO, he practiced in Birdtown, Tennessee over the past 6 years. He's affiliated with Livingston Regional Hospital, received a Bachelor's of Science degree from Tennessee Technological University in Health Science Biology. He's a 2008 graduate of West Virginia School of Osteopathic Medicine. He completed internal medicine training at University of Tennessee Medicine in Chattanooga and infectious disease training at the University of Tennessee in Memphis. Please help me welcome Dr. Todd.
Thank you all so much for having me. The last time I addressed this group, we were knee-deep in COVID, and it was a virtual time we spent together, and I do just really appreciate you inviting me back to get to able to see everyone. And this is a kind of a special day for me. This will probably be the last lecture I get to give, okay? The first rule is no crying, okay? I'm not long for this world, barring some sort of miracle. I probably won't be around in about 3 months. So going out this way is what I find to be a lot of fun. So, forgive me for not being dressed formally. These are the only things I can fit into because I'm carrying about 40 extra pounds of anasarca. So, we're going to talk a little bit about antibiotic stewardship and ways that you can approach the members of whatever institution that you would like to instill this in, whether it be a hospital, a nursing home, maybe even a private office or urgent care clinic, to attain some of the goals to help reduce antibiotic resistance. And this has become a requirement for joint commissions to accreditate hospitals. So a lot of times this is instituted by pharmacists and things like that. They were the first to really take the reins on this. And then my specialty kind of wandered into it and thought, well, we can make this better, of course. But the pharmacists did a very good job. So disclosures, I'm poor, so I'm gaining nothing here. First, we'll talk about, like, well, what is antibiotic stewardship? What are the goals that it tries to create? Look at some of the statistics, and if we have time left over, we're going to go over, excuse me, we're going to go over antibiotics in kind of like a way to help you remember some of these, and I teach this to the medical students, and I've always had fairly good feedback. Okay, so the history, as you know, we first had sulfa drugs in the 1930s, and then somewhere between the 30s and 40s is when we got penicillins, and that was the Alexander Fleming. Then we marched into the 50s and the 60s and the 70s, and you can see what come along. Our next big step was the cephalosporins, but then we had aminoglycosides and things like that. Whenever we get into the 90s and the 2000s, that's whenever we start to see some really severe Staph aureus resistance that forms, and you get all this slew of antibiotics that will treat staph, and then gram-negative resistance rears its ugly head because of overuse of the fluoroquinolones. And we start to see that we're going to need the carbapenems sometimes, and piperacillin just doesn't work as good as it used to, so they added some inhibitors with it, and that kind of resurrected piperacillin. And so today, when we slide into the 2000 teens, the 2020 realm, and further, there's not many new drugs being created. Ceftolozine was the latest and newest cephalosporin. What we see is the development of inhibitors for beta-lactamase, extended spectrum beta-lactamase, plasmid inhibitors, and we're taking our old drugs that used to work for us, we're pairing them with these inhibitors, and once again resurrecting older drugs. Okay, so let's see here. So I think this is the slide about how the resistance patterns developed. Okay, so first you had just simple beta-lactamase. Then the AMP-C developed. AMP-C is interesting because it's an inducible resistance. You don't know that this bacteria is resistant on the standard on the standard plate where they test the drugs until you give it to the patient. They may get a little bit better for a day or two, then all of a sudden they crash, and you redo the cultures, and now it's resistant. And inducible resistance is also seen with clindamycin and Staph aureus, MRSA. Then, after AMP-C, we get our extended spectrum beta-lactamase producers, and they give rise to the carbapenems. Well, now we have carbapenem-resistant gram-negative rods. And there's a question about anaerobes. Are they starting to develop resistance that the penicillin family, the beta-lactam family, and metronidazole may not treat anymore? And then, along with the beta-lactamase production, you have the KPC, which is a metalloprotease. And the KPC has been seen just sporadically through the United States. It was brought to the United States by medical tourists who went to another country, had a fairly affordable hip replacement done, or a chin stuffing thingy, whatever it is they do. And that they get these infections, and the practitioners in those other countries, they go straight to carbapenems. They don't mess with anything else. They go straight to carbapenems. And they've selected out this Klebsiella pneumoniae that produces a tremendous amount of goo. And that goo makes the it's almost impenetrable by the antibiotics, and the antibiotics just bounce off of it in places. So the time that I had to deal with it, it was on a hip replacement. They went in to remove the old hardware and put a spacer in. When they opened it up, about 500 milliliters of just goo, they didn't know what it was, just poured out of this joint. And of course, they freaked out, called me. I had to go get in a bunny suit, which was hilarious, because you can imagine me in a bunny suit. So I get in a bunny suit, go into the operating rooms. First time I've been in an operating room since I was in med school. And I was afraid to touch anything. And let's see here. And I looked at it, and I thought, and I was like, oh no, this is a KPC. And so we only have 2 drugs that can treat a KPC. That is ceftazidime, avibactam, and colistin. Colistin is a detergent. It's not really an antibiotic per se. It's a detergent that we put in through an IV, and it is toxic to kidneys. And ceftazidime, avibactam is a very, very good drug. it has, and it's superior to tazobactam, the avibactam is, because the avibactam will catch the enzyme that's creating this goo, then release it. Catch it, then release it. Catch it, deactivate it, then release it. Okay? Tazobactam grabs it, holds it. And eventually, the bacteria is smart enough, if we just create enough enzyme, we can overcome the dose that the tazobactam is mixed in with. So also the clavulanic acid, same thing. So, so not all inhibitors are made the same. Not all inhibitors are as good as they could be. Okay? All righty. Now, so this is our stewardship. It's very much a team approach. And one of the reasons why we decided that antibiotic stewardship should proceed is whenever Medicare and Medicaid services reviewed data, and our most recent data pre-COVID, because COVID skewed all the numbers for us, unfortunately, 2015 and backwards, you had 75% of patients, no, 70% of patients that came into a hospital received antibiotic therapy, no questions asked. 35% of those people, so half of those folks, either was the wrong drug, the wrong concentration, the wrong, there was some toxicity problems with it. The background, infectious disease doctors take very detailed histories, I know I do, very detailed histories, and help me figure out what's the patient's risk factors and how do I pick my my empiric therapy for the first 24 hours. And then as I get my culture data, I can start trimming it down. Okay, so here's the 6 goals. And as you can see, cost is not listed here. Cost reduction and the burden of very expensive antibiotics on a hospital or an institution, that is a side effect of antibiotic stewardship. And so when it comes to having the administrative body buy in, it's very helpful. Okay? And you see there's the cost things. When you're picking the empiric antibiotic therapy, you want to look at all of these factors, and that's where your detailed history comes in, thinking about if they're in acute renal failure, probably not going to start with colistin. If you're worried about their hearing, they're already partially deaf, don't give them aminoglycoside. Gentamicin has deafened I don't know how many people in this world. Okay? All right. And so that was the statistics that we talked about. Here are the team members. An infectious disease physician is preferred, but not required. So family medicine can do this, internal medicine, anyone that's interested in trying to help reduce consumption of antibiotics and to be more judicious about the empiric therapy is welcome on the team. A clinical pharmacist is excellent. I wish I had one in my pocket at all times. The nursing staff, the infection control nurses, in the administrative level, the CMO or the CNO are very helpful folks to get things rolling and going. Okay, so when you propose, or whenever I proposed an antibiotic stewardship at our hospital, I said to them, first thing, any doctor can order any antibiotic in the first 24 hours. We're not restricting the doctors. They are doing their best. And in the first 24 hours, you really are, making an educated guess. Okay. Suggestions are made, but they're never placed in a chart. Because the last thing you want to do is have a chart with two conflicting recommendations. A plan by their primary care physician, not primary care, of their attending physician, and then this Yahoo infectious disease guy that comes along and says, they probably should be on this. And they just fly through there in the night. They should be reviewed every 48 hours minimum. Some places do every 24 hours. To me, that's a little bit overkill, but every 48 hours I think is a very good sweet spot. Then, let's see here, what else? Yeah. Some drugs do need to be restricted just because of their, because of the danger that they inherently have. So these are just a list of certain things that we restricted in our hospital. And what it was, if the doctors wanted to prescribe these, I said, sure, it's okay. Just give me a jingle and let's go over it together and make sure you got them dosed correctly and stuff like that. And we're not going to have a train wreck on our hands. Okay. And I need to get a little closer to this one. Okay, so now we got about 8 more minutes, and we're going to do some fun stuff, okay? Whenever you all were learning antibiotics, was it list, bug, or bugs, list, bugs, list? And sometimes it got to just be like, this is ridiculous, okay? So these are just some general little rules to follow. So the first thing you want to do is learn the broadest spectrum member of a group. And then you learn the exceptions as you go down the lower spectrum components, members of the family. And I'll show you this here in a second. The next thing is if you swing the pendulum too far one way or the other, say the carbapenems are very heavy gram-negative and anaerobes, it loses a lot of gram-positive coverage. Now, it will cover like a strep or a very, very simple staph, super simple staph. But you don't rely on it to do that. You're using a carbapenem for a whole other reason, okay? So we have our 3 groups here. So first we'll do our beta-lactams. And in our beta-lactams, in the penicillin family, our broadest spectrum is piperacillin tazobactam, right? And it's got its buddy, ticarcillin clavulanic acid. I don't think ticarcillin ever really caught on, per se. And that would be me. I've done that on how many times? Okay. You go down the next, you go down the next group, and you learn, and the important thing here is that piperacillin tazobactam will cover Pseudomonas, but it lacks MRSA coverage because we swung the pendulum, right? Okay. Then you come down to the ampicillin and amoxicillin, and there it swung more to the gram-positive side. And so it's lost a lot, ampicillin unfortunately has lost a lot of its gram-negative coverage. It doesn't cover Pseudomonas anymore unless it's a super sensitive environmental Pseudomonas that, somebody fell into a pond and scraped something, now it's infected. Okay, that was me once. Then, yeah, then you get down to just the plain old penicillin G and penicillin V, and they're excellent for strips. Strips are exquisitely sensitive to penicillin, especially penicillin G, pen G. But that's about all you can hope for. And syphilis. Yay. So, all right. Now, in the cephalosporin family, you've got your different generations, right? So your broad spectrum cephalosporins are your like ceftolamine, avibactam, ceftolamine, tazobactam, and ceftazidime, where they resurrected ceftazidime with avibactam. That's your broad spectrum. They kill out carbapenem resistance and things like that. I leave that off of here because you don't want to go them first line. Those are oddities. Okay. Now, if you have old culture history that tells you that, that's a whole nother story. You know, they were here last week, and now they're back again with the same wound that's kind of oozing. And, turns out that the infusion pharmacy forgot to bring the medicine, and they didn't have it for about 4 days, and they didn't want to bother anybody, so they didn't call anybody. You're like, oh, boy. Okay. Then as you come down, your fourth generations, and then your third generations, the ceftriaxone and cefdinir. Those are meant for strep pneumo. They do have a little bit of gram-negative coverage. No anaerobic coverage whatsoever, unfortunately. And then when you get down to your first generation of cephalosporins, cephalosporins, with the exception of cephalexin, they mainly are used for strips. Cephalexin has strep plus MSSA, or methicillin-sensitive Staph aureus. Okay. And then here's our carbapenems. So our carbapenems, they're like the Three Stooges, Emi, Dory, and meropenem. And then you got ertapenem hanging out there, okay? And so ertapenem should be reserved and only used for ESBL E. coli, and it's a once-a-day infusion. It can be given IM. It's very convenient, but we got to save it. Our other ones, they're all IVs. Imipenem in particular has psilostatin mixed in with it, which is a pharmacologic inhibitor that takes it from 5 times a day dosing to just 2 to 3, depending upon where you're trying to get the drug to. And and they cover Pseudomonas and things like that. They have very little gram-positive coverage, like we talked about. Okay. Then our monobactam, there's one member of this family, Astrionam, and there's always been a debate amongst pharmacists whether it actually works or not. I think it does. It's a good alternative for a truly pen allergic patient, and it does cover Pseudomonas. Okay, so then our fluoroquinolones. Fluoroquinolones, you want to think of above the diaphragm, below the diaphragm. Okay, so above the diaphragm, you've got levofloxacin and moxifloxacin. Below the diaphragm is ciprofloxacin. Now, why is that important? Does ciprofloxacin have very much strep pneumo coverage? Little to none. And Kermit the Frog died of just plain old community-acquired pneumonia, being treated with Cipro at one of the finest hospitals in Los Angeles, okay? And that was just an unfortunate way of finding that out. And that was Jim Henson, okay? Then you get down to the aminoglycosides. Try to avoid them if you can. They can do some gram-positive coverage. And it's very, very small and little, but the gram-negative coverage is excellent. They have no anaerobic coverage whatsoever. MRSA, oral and IVs, and this list is still relevant. And in my final seconds, the D-zone test that we talked about with inducible resistance between clindamycin and erythromycin, VRE coverage here, that became more of a problem. And then I think tigecycline, if it's red, these are important things to know about tigecycline, that these are the things it will not do. And then AMC resistance, that's your spices. If you remember that acronym SPICE-K, there's your spices for inducible resistance against ceftriaxone. And you can read that, and I'm all done. Thank y'all so much.
I'm going to introduce our next presenter, and then we'll do questions for both Dr. Todd and Dr. Hicks. Dr. Audrey Hicks is a board-certified physician by the American Board of Obstetrics and Gynecology. She is a 2007 graduate of UT Martin and a 2010 graduate of Mississippi Medical Center and a 2014 graduate of LMU-DCOM. She completed her OB-GYN residency at Marshall University in 2018 and recently opened a practice in Clarksville, Tennessee with 2 partners. At Queen City Women's Health, she enjoys taking care of women in their pregnancies and gynecologic health. When she's not caring for patients, she enjoys spending time with her husband and son. Please help me welcome Dr. Hicks.
No, you can hang out with me. Good morning. I have just a few things about some common gynecologic issues that you may see in primary care, most commonly abnormal pap smears and where to go after that, and then sometimes postmenopausal bleeding and what the workup looks like for that. Green button. Okay. Maybe. Big green button. Okay, there's 2. Okay, I have no disclosures. So the objectives: determine an algorithm for cervical cancer screening, abnormal pap smear results, and follow-up screening. Differentiate normal and abnormal ultrasound findings on pelvic ultrasound and when a biopsy is needed, and then assess when gynecology referral is needed. So this slide just pretty much says that finally in the U.S., a bunch of groups got together and agreed on cervical cancer screening. And so OBGYN, ACOG, joined the ASCCP, which is the American Society of Colposcopy and Cervical Pathology, the Society of Gynecologic Oncology, so that's who we send our cancer cases for in gynecology. And then they all agreed that the U.S. Preventive Task Force had the best recommendations, and we're going to follow that. This happened in 2019, and then it was reaffirmed in April of 2023. So there was a few changes I was going to talk about with that. The main addition to this was that they added a new test in so that we would not have to do pap smear cytology. You could actually just do a high-risk HPV testing, which is still a swab, with no cytology, so no microscopic analysis, and this is FDA approved now. I know our clinic has not. We use Path Group as our lab, and we haven't had access to that, but it is an option now. So some things that didn't change, screening should begin at 21 years of age. We don't recommend cervical cancer screening before that. And it stayed about the same for ages 21 to 29 in an average risk female, and those older than 65. And then follow the ASCCP guidelines for abnormal results. Now, one of the big things we can do is prevention, and we can do this at our primary care offices. We do that at our office and even at the pediatric clinics. There's been introduction of vaccines, namely Gardasil. I know when I was going through school, Gardasil was protective against 4 of the high-risk HPVs. Now it's protective against 9 of the strains, but there's been over 170 strains that have been identified. The prevalence of HPV with vaccinations should decline, but some areas based on racial, ethnic, socioeconomic areas, there's still some disparity. But the recommendation now, I think in 2013, they increased it to age 26 to 45 for the HPV vaccine, where before it was just to age 25. So now males and females ages 9 to 45 can be eligible for an HPV vaccination. So still under age 21, no screening is indicated. Age 21 to 29, cytology alone, so just a pap smear is indicated. And at age 25, they can be considered for just the high-risk HPV without the cytology, but still a pretty new recommendation. 30 to 65, there's a lot of options. And some patients, we still tell them the recommendations and they still want yearly pap smears, and that's okay. Most of the time, insurance will cover it until their Medicaid age, and then they'll make you go to every 2 years. But these are the recommendations that are current. You can do cytology, so pap smear every 3 years. You can do co-testing, which is the high-risk HPV testing and a pap smear every 5 years, or that new test, the high-risk HPV test. And then no pap smears are recommended after age 65 if they've had adequate negative prior screenings. So that means either 3 consecutive negative cytologies, 2 consecutive co-testings that are negative, or 2 of these high-risk HPV over the 10 years before. And you always have to, use the clinical judgment too. These are based on what our average life expectancy had been for these past few years. If that changes, or if somebody's in very good health and expected to be, living a very long time, or if, on the other hand, if they have high-risk behavior, new partners, and things like that, you may change, what your patient needs. If somebody has had a hysterectomy with the removal of the cervix, no screening is indicated if they did not have CIN2 or higher at the time of the hysterectomy, no cervical cancer. And that's hard. Even in gynecology, some women don't know what parts they still have. So a lot of times I have to ask, what do your incisions look like, and find those old records and stuff. So of course, if you do, on most women, if you do an exam, you can see if there's a cervix or not. It does get harder in menopause because sometimes things just get stuck to everything else. The results can come back as normal ascus, which is atypical squamous cells of undetermined significance, low-grade squamous intraepithelial lesion, high-grade ASC-H is atypical squamous cells but cannot rule out a high-grade lesion, or atypical glandular cells. And then, of course, if you have that HPV co-testing, it can come back as negative, positive, or it can be genotyped for one of the high-risk types. The new recommendations are not really based on results like they were previously. They are based on what their risk in 5 years is of getting CIN3 or higher, so of that precancerous lesion. And so there is an ASCCP app, and I've used some of the algorithms from there. It is about $10, I think, on App Store. I had my husband check this morning, but it can tailor it to your patient, and you can go through what their old screening results are, their age, if it was positive or negative HPV, and what the genotype was if you have it, and it will take you to what the recommendation is for their next screening. So this is just one example that you may see. Sometimes we do a pap smear and it's just unsatisfactory. Pathology did not have enough cells there to identify, and so sometimes you need a little closer screening than what we would do normally. And so for this exact example, if you had no HPV tested, so you just don't know, and there was not enough cytology, they were negative, and you can consider if they were positive, you can just repeat that pap smear in 2 to 4 months. Now, if they were HPV positive, you could go ahead and send for colposcopy to gynecology, and especially if they're HPV 16 or 18 positive, would recommend a colposcopy. 16 is the most oncogenic one, and it's found in over 70% of cervical cancers. And so if we see that HPV, some alarms go off. This is an example. So when we do a pap smear, we'll have that if, it's negative, it's low grade or whatever, but then sometimes it'll say no endocervical or transformation zone seen. And that's the most important part of the pap smear because that's where most of the cervical cancers or cervical pathologies will occur, where those cells change from the squamous to the columnar cells. And so if we don't have that, this is just the algorithm for where to go from there. And it doesn't change a lot unless they are over 30, and if you do see that they are HPV positive, it's either recommended to repeat that HPV in a year or send them for genotyping and then possibly colposcopy if they're positive. But these are all in that app as well. And then this is just an example for what if you see a patient under 25 with some abnormalities. So if they're ascus or low-grade changes, you can just go ahead and repeat the cytology at a year. And then if you want to add the HPV testing onto that and it's positive, you can still repeat. And if it's negative, you can go back to that every 3 years screening. If they have atypical squamous cells with high grade or the high grade changes, then definitely recommend a colposcopy. And then any gynecology referral for an abnormal pap smear is definitely, we would be pleased to see the patient, even if the colposcopy is not what the recommendation is. And then that ASCCP app is very helpful to tailor it to your patient based on their previous results and their age. So it's changing a little bit. This goes to postmenopausal bleeding. Cancer of the endometrium or uterine cancer is the most common gynecologic cancer that we see, and vaginal bleeding is the presenting sign in over 90%. So our body thankfully gives us a clue if something is going abnormal after menopause for most women. So it definitely needs to be evaluated and to rule out this pathology because there's a lot of reasons that they can have postmenopausal bleeding. A pelvic exam is generally needed. You could have atrophy, so low, estrogen causing atrophy and thinning of the tissue, polyps, fibroids, precancerous or cancerous lesions. Even vaginal infections can cause bleeding in some women. And then you can also do transvaginal ultrasound to determine the reason for the bleeding and possibly the risk of cancer based on the stripe. If we see that the stripe is 4 millimeters or less, then it has a 99% negative predictive value for endometrial cancer. Not saying that if that, alarms are there that they have high risk factors that you shouldn't sample their endometrium. You can, but it gives you a lot of confidence that it's probably a benign reason that they're having bleeding. So if you see that transvaginal ultrasound stripe is low, you may not have to do an endometrial biopsy. If you do an endometrial biopsy and you do not get a reason, sometimes we'll just get endocervical tissue instead, or it looks like proliferative changes, something hormonal based. Sometimes we may need to do further testing, and that would be us doing a hysteroscopy with a dilation and curettage, just to make sure that we can sample that endometrium and that uterine cavity a little better. And then if you do happen to see, so maybe you're doing an ultrasound for a reason in a postmenopausal woman other than bleeding and you see a stripe more than 4 millimeters, you don't have to sample just because of that increased stripe if they're not having bleeding. I would definitely individualize it and look at their risk factors. So risk factors for that cancer include, of course, older age, obesity, use of unopposed estrogen, medical comorbidities like PCOS, type 2 diabetes, and if you saw atypical glandular cells on their pap smear. So usually if a patient will come to me for a referral for postmenopausal bleeding, if they haven't had an ultrasound, I'll order that first, and then I will recommend sampling of their endometrium. And I can do that depending on the patient and how well they tolerate exams. I can do it in the clinic along with a hysteroscopy or do it in a surgery center or the hospital. So this is summary. The ASCCP guidelines assess cervical cancer risks, not results, and it's all based on what their CIN3 plus risk is in 5 years. And then postmenopausal bleeding may be the patient's first sign of endometrial cancer or other pathology, definitely should be looked into, especially if it's recurrent or persistent. And then never hesitate to send to gynecology. We would love to see your patient. And that's where my references are.
Any questions for Dr. Todd or Dr. Hicks?
A couple questions for Dr. Todd. The 48-hour antibiotic review that you talked about, who all was, I guess, a part of that review? I think that's one of the things we're struggling in our hospital. We got a fairly robust sepsis program, but with all the consultants that are on board with a patient, there's a lot of hands in the kitchen, and inevitably, like you were talking about, one consultant in the chart says, oh, they should be on this antibiotic or not on this antibiotic and that kind of thing. So I guess, how did you and your experience accomplish a good review of those patients?
So, me, the antibiotic steward, the clinical pharmacist, the nurse that is assigned to the patient that day, and if the attending physician happens to be on the station or things like that, include them as well. The CNO, the CMO, they're more of like the every 3-month check-in. We present our data to those folks, make sure that they're happy with their outcomes and things like that. The infection control nurse comes in handy whenever there's an issue about contact isolation, what's referred to as reverse isolation, things of that nature. So I always had a designated time every Monday, Wednesday, Friday. And then on the weekends, I do it by myself because I didn't want to bug anybody. But Monday, Wednesday, Friday, we had a designated time where we'd all meet together, and we would go from room to room to room to room, reviewing antibiotics and things of that nature. If we needed to go in and see them, we would. But if we didn't, it was straightforward and everything was going hunky-dory, we just kept on moving. And now, you bring up an excellent point of there being the recommendation by the steward and then the attending, but then a consultant that says, oh, well, I want this, I want that, things of that nature. Whenever the steward's recommendations are communicated verbally rather than on the back end, communicated verbally at the time of the decision being made. And I do that, the pharmacist helps me make those calls and things like that. So, but I never put anything in the chart that's contradictory to the attending, because that's just wrong. Okay.
And so were you officially consulted on these patients, or you were just acting in a role as like an antibiotic steward for the hospital?
Some of them I was consulted on, especially those with high-risk antibiotics. We had an automatic trigger consultation for me if, say, somebody was on amphotericin or Centercid or something of that nature. And so, yes, it would be a formal consult on those. And if they asked me to come, I would be more than happy to help. But on the ones that I wasn't consulting on and things like that, I was just the steward that gave a recommendation, and the attending chose to follow it or not. If they chose not to, then I would have a discussion with them. It's like, help me understand why, and I can learn something.
Interesting. I think all that's good. And then one last question. So a lot of the, I'm an emergency medicine physician, so different than I guess a lot of folks here. But in a lot of the bigger national kind of hospital systems, there's a big push around sepsis. One of the measures that kind of is being tracked is, at least at our hospital, is from the time a patient hits the door until the time they get their first antibiotic. Like our metric specifically for septic shock patients is within the first hour. Really what that turns into for us is any potentially septic patient has to get an antibiotic within the first hour to meet the metric, just because of lab delay and all that kind of stuff. But I guess in your professional opinion, does one dose of like an antibiotic for somebody who may turn out to have like flu or strep or something simple, does that affect antibiotic resistance kind of long term? Or is does the focus maybe initially on sepsis kind of outweigh any of those kind of maybe patients who get antibiotics inappropriate? I think we fine-tuned our processes to where that's a little bit lower than it was when we first started, but that's kind of the battle that we're fighting.
Mm-hmm. Yes, you bring up an excellent point. And that magic hour window, I think is a very good idea. And one dose will not induce long-term resistance in that patient. It's dose, 48 hours later, we'll dose them again. And then, we forgot, it didn't exactly get translated to the MAR, and they missed another day, and so the levels go up and down, up and down, up and down. But you get one dose, the flu comes back positive, chest x-ray looks like a viral pneumonia. It's like, okay, we can stop the antibiotics, we'll give them the oseltamivir and see where it goes.
Question for Dr. Hicks. So as a cytopathologist, I'm very curious, what's your thoughts? I know in your practice you said you're still doing cytology plus HPV testing. What's your thoughts about, I guess, cutting me out of the business and switching to HPV testing alone?
I am very, I really want it to stay with cytology. I feel like there's things that we miss, and they're even starting to move towards high-risk self-swabs for the HPV, and so I'm afraid with these new changes, we're already not always doing yearly pelvic exams, which is still our recommendation to still go and get a bimanual exam. And so I'm afraid that if it starts moving in that direction, that we don't have cytology, we're not actually looking at the cervix and the tissues, then we're going to miss something. And I think it does take that experience. Anytime that we're not doing something repetitively, we get out of practice, from things that I've not done now that I'm out of residency because I'm just not doing enough of those type of surgeries. Like, I would hate to be the one to have to do that. So it's the same with cytology. I feel like we still need to do the pelvic exam. We still need to do the broom and actually get those cells off to look at them. So I don't personally plan to send pathology out of business. Yeah. And we do find, some even vaginal infections there that were asymptomatic.
Trichomonas and things like
yeah.
that. But then also things like sometimes we see some H cells that come back HPV negative.
Yes.
So just maybe different types of HPV that are just not being picked up by the test, or certain populations that the testing is just not picking up.
Yeah, there's, we know the 170 different ones that have been genotyped, and we know the 9 highest risk, but there are probably ones out there we still aren't aware of. And I don't think that we need to lose that part in our physical exam and actually looking at the cells. No. Yeah, and that's the thing. They are recommended now, some self-swabs in UK. Yeah. Thank you.
Great. So after that, I now have a question for you, but I have a question for each of you. So Dr. Todd, on the high-risk antibiotic list, you had rifaximin. And I was just wondering if you could explain that, because I did not understand it.
Okay. So rifaximin, a GI-limited macrolide antibiotic, it has a fairly narrow indication. And sometimes physicians will say, oh, I've got another macrolide I could use. They've already had some azithromycin, they've already had some the clarithromycin. Let's give them that. Maybe that'll get this atypical pneumonia treated. Oops. Okay. Of course, it's used for hepatic encephalopathy. It's used for irritable bowel disease, diarrhea dominant, and can be used for C. diff as an adjunct to oral vancomycin or an adjunct to fidaxomicin. Now, you're giving someone 2 macrolides there, and if they didn't have diarrhea before, they sure will afterwards. Yes.
Okay, I feel better about that then, because the only 2 things I really use it for are hepatic encephalopathy and IBSD. But I was curious, I was like, what am I doing here if this is high risk? I just wanted to make sure that I was using it correctly.
No, it's just appropriateness of use.
Okay, and then my question, sorry, for Dr. Hicks. So I have a good number of patients that I do their pap smears. In general, I tell women, if you are, if you've never had an abnormal pap smear and you're not planning on getting pregnant, then I'm pretty comfortable taking care of your pap smears. If either of those other 2 things are going on, like you probably should be at least established with a gynecologist. So I pretty much do either every 3 years or every 5 years. Like a yearly pelvic exam is not something that I do at all. And I'm just curious, most women, like, they just don't like getting a pelvic exam done, understandably.
Yeah.
So is that something that even if we're not doing a PAP yearly, should we be doing a yearly pelvic?
We do as gynecologists, I would definitely leave it up to the patient, and I do always ask them if they want one this year. Are we just coming in for a birth control consult for your yearly this year? We find a lot of pelvic pathology by doing a pelvic exam that maybe they haven't had symptoms yet. There's not good screening for other cancers like ovarian cancers. And so, practice at doing the bimanual exam and making sure that we don't feel enlargement to the ovaries, or odd discharge, stuff like that is definitely something I always offer to them. I'm never going to force someone into a pelvic exam or say this is the only thing we have to do this year. We always have to think about the trauma-informed care, and some women don't want pelvics as very often at all. So I think, no, you don't have to, but I would say, this is what ACOG recommends is yearly pelvic exams, even if we're not doing a PAP. So I would definitely leave that to you and their risk factors, and if they are having any symptoms. And breast exam every time they come.
Yeah, I never do breast exams. I ask the patient if they do it. If they have found something that's abnormal, I'm happy to do a breast exam if that will make them feel better. But otherwise, I just get imaging.
Yeah. And, they don't even recommend self-breast exams anymore.
Yeah, I also explain that to them, but some women really want to do it.
Yeah, and then, so I usually tell them, maybe every month on whatever your birthday would be, just so from your cycles, if there's changes from month to month, hormonally, and make sure that they know that there's caffeine changes that can occur and things like that.
Right. And I try to have those discussions, pick, same day in the cycle every time because of the breast changes that occur. And kind of explain to them, here's what fibrocystic breast changes are going to feel like. But I've just found, again, and I don't know if it's because, women don't want to, I think just in general, women don't really like having, they probably don't want a breast exam or a pelvic exam any more than I want a hernia test done.
That's accurate.
I don't know if it has anything to do with me being male or not. I don't care if it's male or female. I don't really want a hernia test done.
Yeah, it's not fun.
So, I've just found, in general, I try to take a good history. If they have any potential risk factors that I feel like make them higher risk for breast cancer, then we can talk about screening earlier than 40. And otherwise, I've just found, like I said, I'm happy to do a breast exam if they need some kind of reassurance. But in general, I've found that even if I'm willing to do a breast exam, and I tell them, you know what, I think this is okay, they still want the reassurance of imaging anyway. So I'm
Same
like,
with me.
if we're going, like, if that's where we're headed, then let's just not do something that's maybe not super invasive, but also not super comfortable for them, and we'll just get the imaging.
Yeah, and I tell them that they're in their body 24/7. They know the changes, and so if I don't feel something that I think is a high-risk area, I'll still offer that imaging just for their reassurance. And, I can't feel everything. I've lost some of my OMT skills and my little changes under the muscles and tissue. So I'd still offer usually ultrasound under the age of 30 or mammogram over the age of 30 if we have any suspicion.
Thank you.
Welcome.
Question for Dr. Todd. I'm urgent care, so we have a lot of antibiotic stewardship issues in that field. I love Up to Date. I call it my Bible, and I use it all the time. But I feel like Up to Date, in general, loves Augmentin. They're like, it's Augmentin for everything. So I'm wondering if Augmentin is going to be the new Z-Pack. I don't ever really use a Z-Pack because my patients request it all the time, but I feel like it's like taking a Tic Tac. It just doesn't work well due to resistance. So what are your feelings about Augmentin? Are we overusing that? Am I getting in trouble using too much Augmentin?
Okay, so whenever I look at amoxicillin and I'm trying to decide, do I need to add a resistance inhibitor with it? Okay, first thing I do is I look at the age of the patient and I talk to them about, well, how often do you have upper respiratory tract infections? And I'm an internal medicine, so I'm usually seeing adults, every once in a while some adolescents, and then there's 3 little ones at home that that every once in a while need me to call something in, and they're 2, 3, and 8, and so I look at their age first. What's their exposure history? A strep test, you can flip a coin and have just as good of sensitivity and specificity. And so using Augmentin versus amoxicillin, or neither one, trying to educate that most likely this is viral. Let's wait 3 to 5 days. If you're getting worse, then, and so contingency scripts for the patient, things of that nature. Yes, we are overusing Augmentin. That is the truth. Yes. Now, whether or not we use amoxicillin or amoxicillin clavulanic acid, that's where the physician comes in and says, okay, based on your risk factors, your age, your exposures, I think we can do it with this. Now, will they get the ball down and scrutinize it? Some will, some won't. What they're happy for is someone's listening to them. So does that answer the question?
Yeah, I think I was just kind of wondering if you agree with Up to Date or what resource you really use. I love the algorithms on Up to Date, but I kind of feel like they go overkill on Augmentin when maybe something a little bit milder could do the job. So I didn't know what your thoughts were on Up to Date's recommendations for Augmentin most of the time.
Okay, so I live and die by Sanford, the Sanford Guide. That one to me is the best. And of course, you go to UAB and they've probably got one that this is the best we do it. And so that was what I was taught on, and it served me quite well. So I use the Sanford Guide when it comes to any antimicrobial.
Thank you.
Yes, ma'am.
Any other questions?
Can I ask a question? So, in course, with infectious disease, I treat a lot of HIV positive patients. And the emergence of head and neck squamous cell carcinoma, especially tonsillar, and then what's the other place? Base of tongue. Yes, thank you very much, sir. And and then also anal. Okay, in the MSM population. Do you discuss with your patients head and neck cancer, especially those with 19?
Yes.
Doing a swab of their head and neck, and then maybe an anal pap smear if they needed.
And then
something like that.
usually encourage dental exams too, because sometimes those are found at the dentist. You know, it's not something that I'm practiced at looking at for sure. But I do mention, especially with, the 16 and 18, that is a high risk for those other locations as well.
Thank you.
Thank you.
All right, guys, y'all want to take about a 5-minute break and then start it on the next session? All right, guys, we'll go ahead and get ready for our final presenter. Dr. Megan Bill is the Associate Medical Director of the University of Tennessee University of Neurology Center. She is an attending neurologist and an assistant professor of neurology at the University of Tennessee, Knoxville. She is a member of the American Academy of Neurology and a 2016 graduate of LMU-DCOM. Please help me welcome Dr. Bill.
Thank you guys so much for having me come and also for sticking around for the last lecture. I didn't realize I was going to be the ending act today. So I'm really happy to get to talk to you guys about migraines because migraines make up about 20% of referrals to our clinic at the University of Tennessee. And a big part of that is a lot easier when our primary care providers have already kind of understood what things to start prescribing. And so if you're not familiar with the scintillating scotoma, this is kind of an example of if you had someone visiting the Smoky Mountains, what they could be affected by during their visit if they had migraines. This one. This one? Oh, this one. Thank you. All right, so I have nothing to disclose today. The objectives for today's talk is first learning about the classification for migraines and diagnosing migraines, learning about abortive therapies, and then preventative measures and therapies for migraines with talks about the newer anti-migraine medicines, and then differential diagnosis for when you're trying to treat headaches and migraines and they're not seeming to get better, what other things to consider. So from an epidemiology standpoint, about 15% of the American population is affected by migraines, and usually that's a 2-to-1 for females greater than males. And the highest population with migraines are usually females in childbearing age range and also our lower socioeconomic populations. So I don't really have, you don't have to answer out loud, but a couple examples of, which one of these would be considered migraines. So first one being a unilateral throbbing headache that's a 6 out of 10 pain with nausea, photophobia, and lasting for 6 hours. Next patient comes in and they have a holocephalic headache, 9 out of 10, aching pain with photophobia, lasting 10 hours and has to go lay down. Then there's a unilateral headache, 2 out of 10, throbbing pain with nausea, without nausea, but photophobia, and lasts for 4 hours, but is able to continue working during it. And then the last headache would be a posterior 7 out of 10 pain, nausea, photophobia lasting 3 days with significant disability without worsening with cough, sneezing, or laying down. So just kind of thinking through those, is there like a specific one that seems like a migraine, or are they all technically migraines? So we still, even though migraines have been around for a long time, we still don't know the exact pathophysiology for what causes migraines. And I actually had a portal message this week from a patient that said, can you just fix the underlying cause? And I'm like, your MRI is normal. These are migraines. So the underlying cause is kind of like for some patients with hypertension, like you try to address lifestyle things, but if you've got a family history for them, there may not be a thing that we can reverse. So what we do are starting to find out more about migraines is that there are certain neurotransmitters, certain peptides, which is where the CGRP inhibitors came about, and neurochemicals that have been studied to try to figure out what's causing migraines. And then this beautiful kind of breakdown of where all the kind of things that come into all the migraine symptoms outside of the headache, why they cause different symptoms outside of just headaches. So I utilize the migraine criteria that's what's put out by the International Classification of Headaches Disorder. So it is a recurrent headache disorder that is usually lasting from 4 hours to 72 hours. Typical characteristics would be a unilateral headache, pulsing sensation, and moderate to severe intensity, and then usually aggravated by just routine activities. So they don't want to work, they want to go lay down, and then they have to have had at least 5 of those attacks. And they also usually need to require nausea or photophobia and phonophobia. So migraines are more than just the headache. And patients are always, they come in and they're like, I don't know, like the day before, I feel like I stumble over my words. I feel like I just can't think clearly. And then sometimes they'll have an aura beforehand. Most typically it's a visual aura. And then they have the headache. And then they go on and like, well, then after that really severe headache goes away, then I just kind of have an achy headache afterwards and I feel like I'm hungover. And so, most of the time they don't realize that there's an actual phase. There's a prodrome and a postdrome to the headaches. And so usually if they can identify the earlier symptoms, the sooner they can take abortive treatment is usually helps to prevent the longer part of the headache and the postdrome. And then not every migraine has an aura, but it is important to identify auras, and that's usually because patients with auras are at increased risk of strokes, especially with birth control, and so you want to make sure you identify those patients. And I don't usually whenever I'm asking about their history, I don't usually ask them if they have visual symptoms with their headaches, because everyone has visual symptoms with their headache. What you want to know is there ever a warning before the headache starts? That's how I phrase it in order to find out, is there an aura beforehand? And most of the time they'll say, well, it's a dull pain, and then it turns into a headache. But if they say stuff like, yeah, I start seeing flashing lights or a dark spot, or I feel kind of tingly on one side of my face, and that lasts for 5 minutes to 30 minutes before the headache comes, then you can say this is a migraine with aura. So there's all kinds of types of migraines. I mostly focus on migraines without auras and migraines with auras in today's talk, but just knowing that there are hemiplegic migraines, which most of the time those patients are going to the hospital, getting evaluated for a stroke. The onset of symptoms are usually different than a stroke kind of onset of symptoms. Usually it's like gradual over a couple minutes to a couple hours where they start noticing one side of their body is weak versus stroke. I mean, that's sudden onset of symptoms. But still, you want to make sure there's not something else going on. And then ocular migraines, most of the time this is a visual aura that comes on for an hour, doesn't always have to come with a headache. And then migraines with brainstem aura, those are more kind of severe symptoms. They feel off balance, they have dizziness, double vision. And then status migrainosus is a migraine that's been greater than 72 hours. So episodic versus chronic migraines. Episodic is technically less than 15 days, a month of headaches. Most of the time, they usually have the migraine, but then they have the postdrome headaches that come with that. And then in order to have a diagnosis of chronic migraines, they have at least 15 migraine days a month, and 8 of those are migraines. And it has to be for greater than 3 months. And the refractory migraines are usually what we do see in the neurology clinic. These are people that have failed other treatments, and now they're in our clinic still having still having chronic migraines. And then I forgot to change this out from the 2003. I usually like to give a patient a sheet like this where they mark the days for when they have headaches or when they've changed therapies, because a lot of times people, if they're in the midst of a migraine, they're like, oh, it's the worst. But if they have a family member with them, they're like, well, actually, you're doing a lot better than what you think you're doing. You're not complaining as much. So it's really nice for them to have data to look at to see like, oh, yeah, I did start that treatment, and now I have like 50% headaches. So I like to give them just kind of a year or an annual thing to track. For abortive treatment, that's kind of the first place you want to start. Make sure they're educated to take their abortive as soon as they start realizing they're having migraine symptoms. And then are we dosing or giving them the abortive treatment that is best for them? So if they get a lot of not vomiting with their migraines, are we giving nasal, or subcutaneous, or a dissolving tablet? Or if they have stroke risk factors or heart attack or hypertension, then using other things that aren't going to increase the risk of those. This is just kind of another way of looking at abortive treatments. Most people have already started with Tylenol and NSAIDs. Actually, a lot of people with severe or frequent migraines are actually overusing their analgesics, so you have to counsel on analgesic overuse headaches, which is patients that are taking abortive treatments more than 3 times a week. You got to counsel that it's no longer becoming effective, and they're probably now getting withdrawal headaches that they're just taking more and more, so you have to counsel on that. Triptans still work really well. I know the newer agents, a lot of drug reps come around to give samples of the newer agents, but really triptans, there's a lot of different formulations and they still work really well for patients. And so it's a first place that I usually start, but knowing there's certain contraindications for triptan therapy. The newer class, calcitonin gene-related peptide antagonist, are now out, and there's 3 formulations for that. So there's a dissolving tablet, which is the Remegapant. There is a tablet they can swallow, which is the Ubrogepant. And then the most recent one that's come out is a nasal spray, which is the Zavegepant. DHE, I hardly ever admit anyone anymore for DHE for status migrainosus. It still is an available treatment, but there's now nasal sprays that people can use for that. I don't use them that often, but it is kind of one of my, if they've failed everything. Then barbiturates and opioids. I still have some people on butalbital, which is Fioricet or Fiorinol, but I highly limit it to maybe 16 a month. If they're needing more than 16 a month, I'm doing something wrong. I'm not really focusing on preventative treatment. I don't see it as often anymore, but I would see some patients that would come in with 120 a month, which is never okay, because butalbital is an addictive substance, and if you suddenly stop it, you can have withdrawal seizures and a lot of bad things. So over 20 to 30 a month is never, in my opinion, okay. You need to go back and look at what do I need to be doing differently. And opioids. I don't have anyone on opioids, even if they say, well, I had that leftover hydrocodone from something else and I took it and it's the only thing that works. I'm still no, we should really find something else that works better for your headaches. So for triptans, there's all kinds of different lengths of onset and duration. For my migraine patients that their migraine's going to last for about 4 hours, I start with the shorter onset and shorter duration triptans, such as sumatriptan, rizatriptan, zolmitriptan. If I've got a patient that they've tried these, but they're having to repeat the dose, there's longer formulations like naratriptan or frovatriptan, but kind of counseling the patient that it can take a couple hours to kick in. It's not going to be one that's going to kick in really quickly. It's going to take a little bit to kick in, but it's going to last longer. So for frovatriptan, if you've got someone who has over a 24-hour long headache and it's consistent, you could use frovatriptan because it's going to last longer in their system, but it's going to take a little bit to kick in. So the newer ones, the CGRP antagonist, the way they are proposed to work is, one, they help to block neurogenic inflammation through the trigeminal nerve. They help to decrease the artery dilation, and they also help to decrease the transmission of pain. I utilize these in patients that have history of strokes and heart attacks because there's not a contraindication at this time for those treatments, especially with triptan. You can't use triptans for those patients. Something to kind of be aware of is Remegapant is you have to be cautious with medicines that work on CYP3A4, both inhibitors and inducers. So if it's a strong inhibitor, you need to avoid the use. If it's moderate, then they can take it every 48 hours abortively. And if it's an inducer, both strong or moderate, they need to avoid use. And so I can never remember inhibitors, so I usually pull it up and make sure like their list doesn't have any of these medicines on here. The biggest one for neurology is verapamil for me because I utilize verapamil for certain headache types, and so I'm cautious whenever I'm prescribing verapamil. And some of grapefruit juice, chamomile, licorice, things like that, to be aware of. Ask them if that's a common thing they have in their diet. So when you're talking to them about their abortive treatment, sometimes people just aren't using their abortive treatment correctly. And so I'll talk, and they'll be like, well, I wait as long as I can wait before I take it. And really, if they were taking it at the very onset, they probably wouldn't have 3 days. They probably would just have 1 day, and they would maybe only have 1 migraine a week versus they have 3 a week. And so it's really counseling them as soon as you realize you're having the migraine with your aura or your change in the kind of prodrome syndromes, go ahead and taking that abortive treatment. And then also educating on taking another dose if it's not fully resolved within 2 hours before you change therapy. So either increasing if they're not getting full response, increasing the dose, or counseling on taking another one within 2 hours. So this is both just preventative in general, even outside of abortive treatment. Lifestyle is a huge thing. I tell people, I can help you probably about 30%, but I can't come home and shove a 32-ounce bottle in your hand 2 times a day. Like, you have to be well hydrated. You have to know how to appropriately respond to stress, because stress is a big trigger for migraines. I can't do anything about weather changes. People commonly complain that before a storm system comes in, they get their headache at that period. I can't do anything specifically about that, but other lifestyle triggers are really the best way to prevent migraines. And then I'm trying to find things that are not medicines with systemic side effects. So doing physical therapy, osteopathic manipulative medicine. I don't do OMM, but OMM would be a great resource for this, of not having a medication with side effects. And then I also will start a lot of times with nutraceuticals. So they did a nutraceutical trial that was respective, but they had a large group of patient population. And I usually use magnesium and riboflavin daily for patients. It usually takes about 2 to 3 weeks to kick in. Biggest side effects of magnesium can cause GI upset, but for the most part, they're usually tolerated pretty well. And for people that have sleep-related issues or concentration-related issues, magnesium is pretty good to utilize. Except for me, I took magnesium and laid wide awake. So some people will have that, but most people do really well with magnesium and riboflavin. Melatonin, if someone's having sleep-related issues, but I do have some patients that start melatonin and they actually say they get headaches. So that'd be something to be mindful of if you start melatonin. So just a quick kind of putting it out there of preventative treatments we have out there. Some of the older medicines are still good medicines. I know a lot of times people want to jump to the newer medicines because they are technically migraine medicines, but there's cost that comes with that. There's prior authorizations. There's a lot of things that come into the newer medicines when a lot of these older anti-seizure medicines or antihypertensive medicines still work really well for migraines. So I still start there. Because a lot of insurance at this time requires step therapy anyways to get to the newer treatments. And so because they're cheaper, because they still have pretty good efficacy, and because you're going to have to go down that pathway anyways, I start with a lot of these medicines. Side effect profile, so the biggest ones I do utilize are topiramate, propranolol, and amitriptyline, although there's all kinds of different variations in there. With topiramate, knowing that most of the patients you're going to see are in that childbearing age, I do counsel patients that they should not get pregnant on this medicine because of risk of birth defects. So kind of counseling them on that, because a lot of times people, if you're seeing them every 6 months or once a year, they're doing great on their migraine medicine, they may have not realized that they shouldn't have got pregnant on that. If I do have someone who wants to consider pregnancy, I'm usually trying propranolol or amitriptyline, because those can be taken up until pregnancy or into pregnancy for some cases. And then for the CGRP inhibitors, those patients have to be off for 6 months before they start trying to conceive. So onabotulinum toxin is also a good option if you've got patients that you want to avoid medication side effects. It is usually something that they have to have at least 8 migraine days and at least half the month of headache days to qualify for migraine Botox. It is covered by insurance. Sometimes I get patients that get cosmetic Botox, which is how we actually found out it works for migraines. They'll mostly get frontalis and corrugators and Proceris injections, and they notice that their migraines are better. So that's how it kind of came into the neurology world, back into the neurology world for migraines. It is 31 injections, so people that don't like needles don't want to start here first, but for the most part, once they do it, they're like, why did I wait so long to do this? Because a lot of times it helps a lot with headaches. And so it's spread over the front, the sides, the upper cervical, and into the trapezius muscles. And it's every 3 months. So lifestyle-wise, they have to be able to come every 3 months to get it. So just a quick question. 32-year-old female with history of migraines without auras, has IBS, constipation, depression, who presents for migraine treatment. She's currently having 16 migraines a month that are 8 out of 10 throbbing pain with nausea and photophobia. They last 6 hours with significant disability. She's failed topiramate, propranolol, amitriptyline, and triptans. She's working hard to address lifestyle modifications. She's using Nurtec 75 milligrams, oral dissolvable tablet as needed for abortive therapy. She's currently on amitriptyline 25 milligrams at night to help with sleep and depression. She is taking birth control for pregnancy prevention. She is interested in the newer CGRP inhibitors. Which side effect would you strongly counsel the patient about before starting this medicine? Weight gain, injection site reactions, constipation, hypertension, mental fog. So although some of the CGRP inhibitors could cause hypertension, and I do counsel injection site reaction for her, with her already having IBS, constipation, and being on amitriptyline, which can cause constipation, I would counsel about constipation, because the newer CGRP inhibitors do come with a 20% risk of constipation in patients. So now kind of in preventative treatment, we talked about antagonists for abortive treatment. The monoclonal antibodies are being utilized for preventative treatment. For our subcutaneous injections, which include erinumab, galcanezumab, don't judge me, I still use the name brand because it's really easy. Firmanizumab, those are our once-a-month injections. There's slight variations in those. So with erinumab, it is 70 or 140 milligrams, so you have 2 dosing options that you can do. For galcanezumab, it is a loading dose of 2 pins the first month and then 1 pin thereafter. And then with firmanizumab, it is just 225 milligrams, that's once a month, so there's no variations in the dosing. I will switch these. So usually I'll tell patients, most people notice within a week that they're having improvement in headaches. You can have some wear off as you get closer to the next injection, but usually it takes a couple months to truly know if it's going to be beneficial. So if you don't notice a benefit in the first month, continue with it at least 2 to 3 months, and you may even notice benefit even up to 6 months of reduction in migraines. And then firmanizumab and galcanezumab they're both working against the little peptide, versus erinumab is against the receptor. So I still will utilize them because I have some people that are on one and like, I don't know, I don't think I'm getting the full relief. And then we switch to a different variation and they're like, this one's the one, I love it. And then now there's also an IV formulation of that. That's every 3 months. They usually have to be seen by a neurologist to get that one because they have to fill 2 of the injectables, Botox, and they have to have done step therapy with the beginning. So most of the time that one's in the neurology world. And then the oral antagonist, so Remegapant, it can be taken as needed, or if you're doing it preventatively, they can take it every 48 hours preventatively. And then Atogepant is one of our newer ones that's come out that is a daily preventative treatment that they can do. So these are new medicines. They've come out since 2018. So we're collecting data. When they first came out, they said there was only a 1% to 2% risk of constipation. Now that they've been out for a while, that number has actually went up to 20%. And so just looking at potential off-target effects, just to kind of be mindful of things that if a patient says, oh, I know it sounds crazy, but I've noticed these symptoms, then you can kind of be like, I mean, that is, CGRP does work on those things. So already we've seen hypertension with Aimovig, so I'm cautious about prescribing Aimovig in patients that are already having poorly controlled blood pressure, constipation. I'm cautious in that and counseling about it. With pregnancy, although they do say the molecule is pretty small, we still tell patients they need to be off of it for 6 months before starting treatment. And then I'm always curious about wound healing, and I think about that if someone's going through surgery, although no one's said that they've had complications with wound healing. I still think about some of these things that are listed for long-term, in the future, do we need to consider? So this is just kind of putting them all in one place. I know I went over them myself on the other slide, but kind of the different formulations that you can do. 2 of the pens are auto-injectors, which has a pretty good, I had one patient, she went out in the parking lot to do it because they have to come to room temp for at least 30 minutes because they can itch and burn if they don't let them fully stay out of the refrigerator. And she went out and she gave the first injection, and then she was like going to give the second injection. She was like, oh my God, it hurt so bad when I did the one. So, if you have patients that feel comfortable injecting for themselves, there are pre-filled syringes that they can do. And so it's going to be less of that big auto injection. For the injection site reaction, again, if someone says they've had that, it's not an allergic reaction. I usually tell them, make sure that they've left it out of the refrigerator long enough. You can leave it out for a day and it's not going to go bad. And so I tell them to leave it out longer. They can take an antihistamine around the time they're gonna do their injection. So we've already kind of went through these. These are the dosing options that you can do. The Remegapant is just 1 dose. It's just the difference in as needed versus every other day. And then Atogepant is in 10, 30, 60. So prior authorization, and I bring this up because this may change in the future. But what sometimes happens, because I don't know if everyone's from Tennessee and what it's like getting patients into the neurologist for you guys, but there's a 10-month wait time for our clinic. And so most insurances realize there's a huge supply, a huge demand for neurologists. And so they'll have this little loophole in the insurance that they'll cover a CGRP inhibitor for 6 months up until they see a neurologist. And so if you haven't done step therapy, you can get this approved for 6 months, and patients are like, wow, this is great, I love this medicine. And then when they come to the neurologist, we can't get it approved because they haven't went through step therapy. So they've not done topiramate or amitriptyline or any of those medicines. And so a lot of times we're having to basically go backwards and start some of those treatments to get it approved. And so a little bit of kind of, you may experience that if you prescribe the newer agents and you don't go through step therapy, you may get it initially approved and then it may stop being approved after 6 months. So that would be maybe a reason why it's being difficult to prescribe. All right, so for refractory headaches, a lot of times these are people who are like, you've tried everything, you've thrown everything at them, they're not getting better, and so sometimes it's stepping back and, am I missing something? Is it maybe something else that is the headache source, but then it's turning into migraine? So occipital neuralgia is a common one that I see in the clinic. Usually I'm sending them for physical therapy to work on upper cervical treatment. And I see Dr. Whiting in the congregation or in the conference today, and I'm in Knoxville, but I don't really know of a great DO that does OMM, but I think OMM would be a good thing to focus on for occipital neuralgia, because most of the time it's trying to relieve the musculoskeletal or like cervicogenic source of the irritation. If you've got patients that are having morning headaches, so the things that can cause morning headaches, if they're at risk for OSA, it's really important to get a sleep evaluation because they're probably having morning headaches because they're not getting in enough oxygen. Or the other thing that can cause morning headaches is idiopathic intracranial hypertension, which used to be called pseudotumor cerebri, but then everyone thought they had a tumor, so we stopped calling it that. Tumors can also cause morning headaches, so those are other things to kind of evaluate. Is there a secondary source if they're always complaining about a morning headache? Analgesic overuse headaches, and that includes all kind of Tylenol, ibuprofen, Aleve, Excedrin, hydrocodone, things that they're on for other pain. We may not be able to fully get them improved with their headaches if they're overusing their analgesic medication. So finding out your headaches seem to increase. Was there a new medicine that was started? There's other neuralgias or other headache types to consider. And then secondary headache is always that one that people get worried about, like, is there a tumor or is there something else that's going on? So the SNOOP-4 is the thing to look for secondary headaches. Are they having night sweats? Are you concerned about metastatic disease? Or do they have temple tenderness? Are they in the right age range for like a temporal arteritis? Is it like more of a subacute worsening of headaches? Do they have a CNS infection? Any focal neurological symptoms that are even present outside of the headache? That's important. For headaches that could be related to increased intracranial pressure, both the idiopathic form and the secondary form, looking for changes in their vision, which is more peripheral vision loss, obscurations where they get grain out of their vision, worsening with coughing, sneezing, bearing down, and pulsatile tinnitus, which is not a ringing. A lot of patients with migraines complain about just a little high-pitched ringing sound. Pulsatile tinnitus is a whooshing that they hear, and it's usually worse when they're laying down at night. They'll hear this whooshing sound in their ears. Sudden onset, thunderclap, they feel like they've had a bolt of lightning at the top of their head. Those are more concerning for stroke type, abnormalities in the blood vessels, so vasospasm. Dissections can be part of that. And then anyone that's over the age of 50, if they've never had headaches before, or they really didn't have a lot of headaches and all of a sudden they're complaining about headaches, I want to make sure that there's not a secondary cause. Positional, if it's at night, if it's worsening with bearing down. And then if they are pregnant, most of the time with pregnancy, people don't have migraines and headaches. They actually feel better. And so if they're pregnant and they suddenly start having a headache, you want to be worried about some of the differential diagnosis and anything that could worsen pressure inside the head. Best imaging modality, CT scan. Unless you're in the ER, it's not going to be useful for just a CT head. It's going to tell you about a brain bleed, or if you've got a tumor big enough that's pressing on something, or you've got a stroke that's over 72 hours old, but it's not going to tell you about small tumors, posterior lesions, any of that stuff. So really an MRI brain with and without contrast. If you're worried about they're having worsening headaches with coughing, sneezing, you want to look for a sinus venous thrombosis, and then a CT angiogram can be useful if it's those thunderclap headaches. Most of the time those people go to the ER. They don't usually come to your office, but there's always those people that you're like, oh my God, why did you come here? Why didn't you go to the ER? So I usually tell people if they have any worsening of headaches, the ER's the place where they can get the test done a lot quicker. So key closing points. First steps in improving migraines can be accomplished by proper patient education regarding lifestyle changes, making sure they're drinking plenty of water, eating like meals consistently, trying to find triggers. So keeping a good journal helps with them finding their triggers, and then proper utilization of their abortive treatments. When treating chronic migraines, using step therapy can help with the cost of medications because a lot of the generic medicines are cheap. I mentioned that there's a high population of migraines in our low socioeconomic patients, and so picking medicines that are expensive are not going to help them if we can't get them covered, or even if they have a copay that's $50, most of the time people can't afford that, and so some of the medicines that are more affordable. And then when considering new prescription medications, documentation about properly documenting that they have migraines, how many migraines they have, and then what they've tried previously can really help in getting your prior authorization smoothly done instead of having to do peer-to-peers. And then there's a lot of migraine therapies available now, and so even though the wait time can be long for the neurologist, I still like treating migraines because it's the one thing in the neurology clinic that's not going to kill them, and so it does affect their quality of life, and so most of the time they're the people that I can make better, and so I do like seeing migraines because a lot of time it's just sitting, listening to their life and trying to figure out how you reduce stress. I don't know how many people are like, they get headaches at work, and I'm like, so I mean, like, do you really keep taking a medicine just to keep a job? Like, you're on a lot of medicines, and like, but I gotta have this job, and then for whatever reason, they don't work there anymore. And they're like, oh my God, I don't have migraines anymore, and you're like, stress is a big component, and so sometimes it's just having that talk to be like, is it really worth all the medicines you're on? Like, is there any consideration? And most of the time that's hard to say to people. I try not to be like calloused about it, but a lot of times it's like, like, is there something better? Like, there's more out there. Is there something better to consider? So, and then the resources that we used. I'm sorry, this did not have a lot of discussion about urgent care. So ER, urgent care, dosing for migraines or pregnancy.
Hello, I'm an ER doctor. What's your favorite ER migraine cocktail after we rule out all the bad causes?
So most of the time, I know you guys usually use Toradol, do Benadryl, and an anti-nausea medicine like Compazine or Phenergan. Against patient popular belief, Benadryl is not a treat for migraines. It's just to help with the acute dystonic reactions from the anti-nausea. If that's not knocking it, when I was covering ER, I'm outpatient now, but whenever we were doing neurology coverage, IV magnesium can be an abortive treatment. IV Depakote, 500 to 1,000, especially if they're not pregnant, can be utilized. IV levetiracetam, Depakote would be valproic acid. IV levetiracetam, 1,000. Those are some of the other abortive options you could do if they seem to be lasting. Sumatriptan, I don't know, do you guys utilize that in the ER, the triptans? Do you guys have triptans in the ER?
And one of the things on Up to Date was like a triptan was kind of one of the first line things.
Yeah.
I think they said to use in the ER, which I personally never gave in residency. I've never gave in practice, but I guess from your standpoint.
Most of the time they've already used it though. Most of the time they're there because their abortive didn't work. And so the only reason why they may be there is because they don't have someone prescribing a triptan. So that would be something to know. But most of the time, once it's a full-blown migraine, triptans are kind of hard to work backwards from. So if they're like going on 24, 72 hours of migraine, triptans are kind of hard to stop it. So most of the time when people are calling, I'm trying to prescribe, I'll do Depakote 500 twice a day for a couple days in the outpatient setting. A lot of times they'll go to their primary care doctor, they'll get a steroid shot and a toradol shot to try to abort it in the clinic setting. And so once they're in the ER, it's really trying to give them IV fluids to try to help with nausea so they can keep things down, and then trying to give a pain medication to stop it. And so that's why I usually like doing some of the anti-seizure medicines, because, you know, a lot of that neural pathway is prevented or stopped by like anti-seizure medicines.
Any role for like Decadron? And then, you know, I know the other things that we've used, some people have gotten admitted for like IV caffeine or like IV ergotamine or, you know, something
Yeah,
like that.
and that's usually you're going to be getting your neurologist on board if you're doing DHE. If you're going to do a steroid, Decadron's more for vasogenic edema, so like tumor related. So most of the time I'll recommend methylprednisolone. And if I'm in the outpatient setting, I'll sparingly use a steroid dose pack to kind of break the cycle. The last thing I would say is you get into kind of a sticky situation when you start giving opioid treatments. I've had some people say like, oh, my friend down in Texas gets Demerol, and I'm like, well, this ain't Texas. Like, so I would say that's one place not to go, because they do kind of like, it's kind of can create bad habits. So that's usually where I say to go in the ER with the IV seizure medicines, because for the most part, those aren't going to come with huge side effects or risk with them if you're just giving them in a short course. And then if it's status migrainosis, is it's 72 hours and they're still like having a bunch of migraines, then if you've got a neurologist that covers for your hospital, then consideration for DHE or daily IV steroids that can be given over a couple days.
And the Midral dose pack you said sometimes you'll do as outpatient, like would that be a patient, say they're in like status migrainosis, we somehow get some improvement in the ER, would like that be a patient
That would.
with like a Midral dose pack discharging them if there's no contraindications that we could do?
Yeah, so it's someone that's been they've already tried their abortive, they've done Nurtec, they've done their triptan, they've taken the NSAIDs, they've done all of that. It's their typical migraine. It's not like they're like having new symptoms. Then I'll do a Medrol dose pack, and I'll consider Depakote or levetiracetam depending on the patient population.
Then I guess one other question. I think in emergency medicine specifically in the last, I would say 5 to 7 years, we seem to be ordering more CTA heads for headaches and that kind of stuff. I didn't know if you had seen, even our radiologist had, commented, on that practice kind of change. But I didn't
Like
know,
they were supportive of it, or they were not
just
supportive?
saying that it was happening,
Yeah.
I guess. So from, I guess, your perspective, from a neurology standpoint, have you seen that more? Has there been recommendations where, from y'all's standpoint, they changed to where we should be doing more of that, even from an outpatient setting? Like for a headache, is a CTA head and neck, is that a worthwhile addition to kind of either the ER or outpatient workup?
It would depend on the headache type. If it is a migraine, like unilateral pulsatile, if it's that with maybe some blurred vision or things, I would not do a CTA. If it's something where they're like severely dizzy, like the brainstem MRI that I was talking about, severely dizzy, or they're having neurological symptoms on one side, or they're having positive neurological symptoms, then I'd say a CTA. Or if it's a thunderclap headache, you can have a primary stabbing headache. You can have things that are not RCVS, which is the reversible vasospasm syndrome. You can have those things, but that is when I would do a CTA, is if they're having neurological symptoms with that sound that make you concerned for stroke, even though they don't describe a sudden onset. But CTA, I wouldn't do that all the time unless I was really worried about a dissection or like a primary CNS angiitis or a RCVS or something like that. With the reason why I do bring up positional headaches is because that can be the early symptoms of a venous, like a sinus venous thrombosis. So patients that are waking up with a severe headache in the morning that's causing them to vomit, they're having some visual, like peripheral visual issues, and they're saying like, oh, it's just like pulsing in my ear. Then I would think like, okay, you need an MRI and you need a CT, or you need an MR venogram to look for either a sinus venous thrombosis or a tumor of some sort.
I also work in an ER, and one of the things that we use as part of our cocktail is Norflex. What do you feel about muscle relaxer use for the immediate cocktail?
Norflex, is that
It's a muscle relaxer.
Ofinidate?
Yeah.
Okay. I do use muscle relaxers for certain headache types. So if they've got a lot of posterior pain, they're saying they get a lot of tension. Because most of the time when people are in pain, they just they draw up and they get all this pain. So I do utilize muscle relaxers. I don't usually use Norflex a lot. Not saying that it's a wrong answer, I just don't use it a lot. I usually do tizanidine or cyclobenzaprine for some people. Sometimes it's just trialing because some people respond better to one than the other. Methocarbamol is another one I use. So it is something you can use, especially if they are getting a lot of like posterior tension pain.
I think we use that one mainly because it's IV and IM. Other ones,
Okay.
they're all oral, and everybody comes in vomiting with them.
Okay. What would you say your success is with it?
Well, the problem in the ER setting is that the most of the people that we get for migraines are what we call our frequent flyers. And a lot of times they're really looking for narcotics. Sometimes the basic cocktail, which you've described with the Toradol and the Phenergan and Benadryl and maybe Solumedrol IV, that will work for people who I feel like have legitimate migraine stuff, but a lot of times we just see people looking for narcotics. So we're kind of just trying to offer them anything that we can give them without giving them narcotics.
Right.
Just frequent.
Yeah, because it potentiates that behavior, right? You know, and I don't think they start off with that in the mindset, but you know, it does get to where that's the only place they can get it. Because like even I have a few people I've inherited that they got like 5 oxycodone every 3 months, and then before I know it, they're needing 7. And that's really not a lot, but before you know it, like it's this slippery slope of like they're wanting more and more, and then they're getting them other places to. So, I'm glad that you guys try to find other options. So I guess I didn't realize Norflex was an IV option that you could do for them. So that probably gets it in quicker, and they're able to be discharged sooner.
I'm excited to try the Depakote now.
All right, we have time for one more question.
So I noticed on your pinwheel there was an awful lot of lifestyle stuff, and one of the things that you mentioned was like lower socioeconomic status. And I may have overlooked it, but I didn't see anything directly associated with like obesity, and I didn't know if you do any counseling on weight loss or if you've seen any improvement in migraine frequency or intensity with weight loss.
So I don't have anything in there about obesity for this talk. Obviously, if there is obesity and they're not exercising and they're not active and they've got poor musculoskeletal strength in their like upper spine and shoulders, they'll have more headaches. I do more counseling regarding obesity and intracranial hypertension because there is a study that shows that at least 10% weight loss can basically resolve intracranial hypertension. And you know, it's hard the first time you see someone to like, you're trying to build rapport and then you're like, you know, well, like you need to lose weight. So, there does take some of that, you know, let's treat it. And then I do mention like weight, like obesity or rapid change in weight can contribute to headaches, especially intracranial hypertension. But from a standpoint of just overall health, it's important to counsel on weight loss. Because, I mean, that's going to help with high blood pressure, obstructive sleep apnea. So I don't get it in on every patient that I see. Because really, in my patient population that has migraine, the vast majority are not obese. And usually the obese patients that I do see are usually the ones that have very characteristic sounding symptoms of intracranial hypertension. So that's when I am utilizing that to be like, the medicines, there's limited medicines for IIH. They all suck when it comes to like side effect profile. They make you tingle, they make you foggy headed, they make you like hate the taste of pop, which is probably a good thing. But I'm trying to give them other resources. I don't think I completely answered your question. I do counsel about weight whenever it comes to those type of headaches. Any other questions? Thank you.
Before Amy gets up here, I just wanted all of us to recognize Amy and all the hard work that she puts into this conference every year. You know, from her standpoint, getting speaker invitations out, getting all the speaker CME required materials out, and then trying to get them back in, getting the vendors for the food, the audiovisual guys, and also thank you to the audiovisual team back there as well. But for everything that she does to put this conference together, there's a lot of work that goes on behind the scenes that really takes the whole year from the time this conference ends till this conference next year. So before she got up here to do the housekeeping things, I just wanted us to give her a round of applause for everything that she does.
Yes, so hello everybody. As Dr. Cope said, I'm Amy Drittler. I'm the Director of Alumni Services and CME at LMU-DCOM. So this conference is very important to us because it combines alumni and CME, my two favorite things. I'm going to quickly walk all of us through the attestation process, both in person and online. So bear with me just a moment. We're going to start with our in-person attendees. If you are a DO, if you will please raise your hand, and my colleague, Ms. Emily Engel, is going to bring you your attestation form. So while we're doing that, I'll now talk to our online audience for a minute. If you will go to the downloads link that's at the top of your web page there, you should see right at the very top of that next page that it takes you to the attestation forms. So you need to choose the one that's appropriate to your profession. There is one for DOs. There is one for all other professions. You will need to complete that fillable PDF and save it to your computer. Please make sure that there is a visible signature on your form. It's okay if it's an electronic signature. It's okay if it's one of those time-stamped Adobe signatures, but there needs to be something visible in that PDF block for the signature. And then if you will email it to me as an attachment, and we will give you all of these instructions on how to do this through email as well. You can certainly email it to me this weekend at amy.drittler@lmunet.edu. You should have gotten some emails from me this weekend. Otherwise, we'll send an email out to everyone, virtual and in person both, next week with all the instructions on how to wrap up this paperwork. Okay, back to my in-person audience for a minute. If you are anything but a DO, please raise your hand. Ms. Engel's going to come around with your attestation form. So from everybody that's attended this weekend, we would hope to get two things back from you. One is your attestation form. One is the program evaluation. We do take your comments on this conference very seriously. We select each year's topics directly based on what is requested the previous year. So help us plan for next year by letting us know what other topics you'd like to see in this conference. And I'll stay up here just a moment. I think that you could still submit a question online if the online audience has any questions. Yes, my AV team is saying yes. And we do very much thank you all for attending this weekend. This is an annual conference that takes place the second weekend of June every year. Next weekend, we will be at the new Heartsong Resort next to Dollywood. It will also be hybrid, virtual and in-person both. So please mark it on your calendar now, make plans to join us. Next year, sorry, did I say this weekend? It's been a long few days. Next weekend. And bring a friend, yes. We thank you all for your support of our Alumni Association and of this conference, and we do hope to see you again next year.